I figured that if I just.
Okay, we're recording.
All
right.
You know, he would jump out if he was going
All
straight.
Good evening, everybody. Welcome to the regularly scheduled board meeting of Kittitas County Public Hospital District Number 1. It is May 26th, 2022. Mandy, can we please start with a roll call?
Yeah, Erica Libanow,
I am here.
Matt Altman,
Here.
John Ward,
Here.
Terry Clark,
Here.
Bob Davis,
Here.
Julie Peterson, here, Scott Olander,
Here.
Stacey Alea, here, Vicki Mataro,
Here.
Dr. Martin,
Here.
Dr. O'Brien,
Here.
Andy Olson, here, Kelly Goodien,
Here.
and it looks like on Zoom we have Rhonda Holden, here, Michelle Worrell, here, Jason Adler,
Here.
Jeff Yamada,
Here.
Amanda Scott,
Here.
Ron Erlacher.
Here.
All right,
That's everyone.
thank you so much. Let's start here with approval of the agenda.
I'll move to approve the agenda as. I second.
Moved by John, seconded by Terry. All in favor, please say aye.
Aye.
Aye. All opposed, say nay. Carries. Very good. Consent agenda. Seeking a motion to approve the consent agenda.
Move.
Moved by Bob,
Second.
second by Matt. All in favor of approving the consent agenda as written?
Aye. Aye.
Aye. All opposed, say nay. All right, that carries.
And I think it might be good, even though it's not on the agenda, I think when we get to education board reports, maybe just for the record, we might say something about our retreat that we just had.
Yeah.
I mean, I don't think it needs to be added to the agenda, but it might be nice to just get it in there.
Sure. All right, cruising right along to public comment and announcements. If anybody would like to make a public comment or announcements, please state your name, your address, and please keep your comment to 3 minutes or less. And please understand that the board does not respond to public comment during the meeting. Anybody here or on Zoom would like to make a public comment?
Unmute that person.
Sure.
Hi, this is Lisa Bliss.
Good evening, Lisa.
Hi, I'm a resident of Ellensburg. I'm at 331 Bountiful Lane, Ellensburg. And I'm sorry if you can't see my video. I'm not a Zoomer. So, but I hope you can hear me.
Hear you loud and clear. Thank you.
Thank you. And thanks for the opportunity for letting me speak. I just wanted to speak briefly about informed consent in the emergency department, specifically for pregnancy tests for women. I was a patient in December for chest pain and had excellent care. And I received a bill. And as I always do, I request an itemized bill. I received the itemized bill and I was surprised on that itemized bill that a pregnancy test had been done without my consent. And I was surprised because it's my understanding that at least at other emergency departments where I have happened to have been a patient, that if there was a concern, you know, for needing an x-ray or needing a medication and the possibility of somebody could be pregnant, that I have always been asked, is there a possibility you could be pregnant? And if I said, you know, there is, then pregnancy test certainly would be, you know, appropriate. But I was always given that opportunity to ask, to answer the question. And there are a number of reasons why somebody might know for sure that they're not pregnant. They could have had a hysterectomy. They could be postmenopausal. They could maybe have not had sex in the last year. And if a woman is asked, you know, under those kind of circumstances, is there a chance you could be pregnant? I think that she can be trusted to say no. And then, of course, if there is any uncertainty, I think it's very appropriate to consent to a pregnancy test. And so I have brought this up with a couple of people there, and I have been very happy about the reception to the issue and the opportunity to discuss it. And I just feel that it is very important that we ask for informed consent when at all possible. Of course, not for, emergency trauma or whatever the emergency department protocols are. I just think that the informed consent for pregnancy tests is very important. And not only for autonomy, but also for healthcare savings. It was $101 that was billed to my insurance company. And then, of course, my portion of the bill as well. But the primary concern was actually the consent. And that is it. And I appreciate very much the opportunity for letting me speak up. Thank you.
Thank you, Lisa. All right, any other commenters or public announcers? Okay, all right, we will move along to our presentation with Tom Dingus from Dingus, Sarkar and Associates PLLC of the Financial Audit. Welcome, Tom.
We've got two people on the phone, Tom, and we also have Ann Strand, who's with the state auditor.
All right,
Doing this.
welcome, Ann.
Thank you, and she's listening on the audit.
All right.
Thank you, Ann.
Thank you. I appreciate the opportunity to come and listen today.
Well, good evening, everyone. I'm Tom Dingus from DZA, and I'm going to do the audit presentation this evening like we've done in the past. And just a quick intro. I think most of you know me and our firm, but CPA firm located in Spokane Valley, 4 other partners and about 40 people in our firm. And we work 95% with healthcare, primarily critical access hospitals and other rural healthcare in the Western United States. 2 reports I'll cover tonight in the audit presentation, the actual audit itself, and then the financial indicators, kind of the more visual representation of the financial results. I met on Tuesday morning with the finance committee. So I've already kind of went through it and probably about the same presentation, but maybe a little more detail in that presentation than this evening. And so please ask questions anywhere along the way. I'm going to share screen and please let me know if you have any questions. Right. So starting with the audited financial statements, I'm going to kind of scroll through these as we go, sometimes quite a few pages, but so starting a couple pages in is the independent auditors report. Just showing you the top part here. I think most of you, the board would have copies of this, but I'm trying to get the right size here. It's the first of 3 audit reports you'll have in the audit this year. You usually have 2 because as a public hospital district, we audit in accordance with government auditing standards each year. But this year, because of the federal awards exceeding $750,000, it was also you're also subject to a single audit. And so there's a third auditor's report we'll cover in a bit. So the first audit report, unmodified opinion on the financial statements, which means that the financial statements that follow present fairly the results of operations and the financial position of the district. If you compare the report to last year, it is a different format. Auditing standards have changed in how the report is structured. Substantively, it's still the same thing. It's still an unmodified report. What we're giving, it's longer, better structured, and much more transparent about the audit process. Includes sections on opinion and the basis for the opinion, the responsibilities of management, the responsibilities of the auditors. Much longer and much more transparent report. I'm not going to go in any great detail on that, but it does describe the audit process better than probably the previous reports did. So there's that. And then a couple pages after that, it starts with management's discussion and analysis. This is condensed financial statements and also includes kind of the MD&A or management discussion analysis that's prepared by management that essentially provides a narrative or story to go with the financial statements of what the numbers mean. it's a good place to go back to if you're looking at the financial statements or the audit later for the kind of the quicker version of the financial statements and what happened. I'm gonna skip through that as part of the presentation today, but it is there for that purpose. And then skipping ahead to the main part of the financial statements with the balance sheet or the statement of net position, as it's called in a governmental entity. And I'm only going to really hit on the significant things or anything you might want to ask a question about as we go through here. Not any real big changes on the asset part of the statement of net position. A couple of things to point out on the liabilities and net position page is you'll see a estimated third-party payer settlement liability of $2,347,000. Nearly all of that, well, $700,000 of it's a reserve for some prior year cost reports. Most of it relates to the current year's cost report. And there was a lump sum adjustment that actually was paid early in January, like on the second or third day of January, of $1,933,000. The actual cost report that I believe Scott and Jason and team are filing tomorrow is pretty close to a net zero because it filed on the basis of that 1.9 million being paid back. But as of December 31st, 2021, about 2.3 million estimated owed to Medicare. And why that's probably higher than, I mean, not probably why, but why it is higher than normal and what you would expect is Medicare pays interim rates throughout the year. And the 2021 interim rates were based on the 2020, for the most part, based on 2020, which was the year with lower volume, higher cost because of the COVID pandemic. And so in a sense, you got underpaid in 2020 and had a receivable at the end of the year. And 2021 is the opposite with where you're overpaid essentially through the year and owe the money back to Medicare. And as a critical access hospital for the Medicare part, you get paid pretty much exactly cost for your inpatient, outpatient, and rural health clinic services. And so hopefully in 2022 and forward, it gets to be kind of less variation in what that settlement's going to be from year to year. The other thing to note is the Unearned CARES Act Provider Relief Fund. You'll see a little less than $2.3 million there. That is the phase 4 and ARP distribution that was received shortly before the end of 2021 that will be used for COVID response preparation, so forth related to COVID in 2022. It could be used from essentially anytime in 2020, 2021, and 2022, and you'll use it for 2022. And so it'll get recognized as revenue in 2022. And then that's, there'll be a couple things we'll come back to in the financial indicators, but that's the main things there. And then you get to the, and the theme of this presentation will be that it's a pretty easy presentation to give because it's all good stuff. Oops, too far here. Is the next one is the statement of revenue and expenses and changes in net position, and a 28% increase in net patient service revenue, as obviously 2020 was impacted by the COVID pandemic more than 2021 was, and then just essentially growth in service lines and volumes and utilization of every service line was up from 2020 to 2021. But the bigger takeaway of all this is that the expenses were up, salaries and wages were up 11%, and total expenses were up 13%. So a big, the increase in revenue much more than the increase in expenses. And you can see the operating income of $15 million compared to $1.3 million in the previous year. You see the significance of that again in the financial indicators in a little bit, but that's really good. CARES Act, this non-operating revenue, you can see the COVID relief coming through, and CARES Act Provider Relief Fund, the money that was received in 2020, how much, about 3.1 million was recognized in 2020, and another little less than 3.3 million recognized in 2021. And so, and like I mentioned earlier, there'll be the additional 2 million or so that'll come through in 2022 as revenue. To your bottom line of net change in net position or net income of about 18.5 million compared to 6.4 million in the previous year. So very strong results, obviously. That's what that tells you. And then moving on, the statement of cash flows. I'm not going to go through this in any great detail. And then moving on to the notes to the financial statements, and I'll just hit on a couple high notes through here but first, for the financial statements, I always like to start with that the notes serve three purposes of like primary purposes. The first part, the reporting entity of who you are as an organization or what the entity does, public hospital district, how it's governed, the services and the like. And also talks about the related entity of the foundation. And then the second purpose is the summary of significant accounting policies that tell how different balances and transactions are recognized and recorded in the financial statements. Great reading to understand the financial statements. Not so great that we're going to read it right now. We'll save that for later. And then I'm going to really skip through here, so it's going to be like whirlwind here, but just hitting on what's significant to note in the notes is the capital additions in went too far there. In 2020 and 2021 and 2020 are showing these couple statements here. And then you got your long-term debt. No new debt was issued in fiscal year 21. There was a smaller capital lease that was added. And then you get, I think the important part is you can see the future debt service on this page of what the district has in outstanding LTGO bonds and revenue bonds and capital leases that are due over the next few years. And then moving on, another one I always like to touch on real quickly is net patient service revenue, of how much of a hospital, any hospital, but your hospital's revenue comes from Medicare, and it's 37% of your net patient service revenue is from Medicare, and another 16% is from Medicaid and the Medicaid managed care program. So just about 53% there as well. Yeah. And so quite a bit comes from commercial payers. And then a note I don't normally talk about too much, but commitments under non-cancelable operating leases. And why this is important is it will be the last year you see this, because these types of leases will become capital leases for what is called now in 2022, and that the obligations under these leases will show up as right to use asset, right of use assets on the balance sheet, and lease obligations on the balance sheet as well. So you'll see an increase in assets and debt obligations on your financial statements in 2022 for any outstanding lease obligations. And so that'll add to the debt, but they doesn't change the impact on net income much. There's a little bit of timing difference, but essentially the economic impact is exactly the same. It's just going to add these liabilities with the idea of presenting a truer picture of the obligations of any entity. And then in 2023, things like your arrangement with Cerner could potentially also be recorded and essentially like a lease as well, with an asset and a lease, depending on the terms of the specific agreement. If they're one-year agreements that are just renewed each year, it wouldn't show up this way. But if it's a long-term commitment, it'll be recorded with those types of obligations. And this has a big impact on hospitals. This particular, it's called subscription-based IT arrangements, but it's really applicable to the healthcare industry as the significant cost that's incurred for EHRs and patient accounting system and revenue cycle systems that makes it very pertinent to your organization. So will be some changes to the financial statements in 2022. It's easier to say. And then actually also some other changes you're going to see in 2022 is with joining the PEB for your health insurance benefits for your employees in 2022. There'll also be about 4 or 5 pages of disclosures related to the PEB and some actuarial liabilities and some expenses related to that, with the obligation of the PEB as you go forward is that the PEB's open to retirees. So there's a amount of implicit and explicit subsidy that goes to retirees that are eligible for the plan that's recognized in expenses and liability by being in the PEB. And same with other public hospital districts and entities within the state of Washington record. Any questions so far? That's the main part of the numbers.
I think we're good to continue.
All right. Next up is the second of the 3 auditors reports. This is the report in accordance with government auditing standards where we give our report on internal controls over financial reporting and compliance. And the main takeaways of this is that there are no material weaknesses or significant deficiencies, or otherwise known as findings, reported for the district this year. And I don't think you guys have had any, you've had any for a couple of years or several years or for quite a while, actually. And then the next audit report is new to the district this year. This is the report that is it's much narrower in scope, where we just report on internal controls over compliance and compliance for the major federal program, or the federal award, which is the Provider Relief Fund. And this will also be necessary in 2022 as there's some more reporting that has to be done on the Provider Relief Funds really through the end of 2022 on the amounts that are received. And it's just focused on that narrow scope of the audit, and there are no findings reported on the Provider Relief Fund as and the single audit either. So that's good. And then moving on, this just is a summary of the auditor's results. That's part of a single audit package. It does just really say what I've already summarizes everything I've just said about the single audit and audit in accordance with government auditing standards. And then further on, you have the schedule of expenditures of federal awards, which does show the amount that's been expended or for federal awards by the district in 2021. And Provider Relief Fund is unique, and it's not really what was expended in 2021. It's what was reported in the reporting period ended June 30, 21. And if there would have been a second reporting period for applicable December 31, 2021. That's a little odd, but in any event, this was necessary because the Provider Relief Fund kicked you over the $750,000 threshold for the single audit. And there were no prior year audit findings. Any questions?
Does not seem so.
All right. I try to anticipate what the questions might be so I can answer them before you ask them, but there's always more. So the second report is really a byproduct of the audit. It's not required by any standards, but it's where we add this to help show what the numbers all mean in a more visual way with some trends and then relationships to the size of the organization. And then for some of the particular indicators, some medians from like type hospitals to compare to. So putting things in perspective. And starting with total margin, generally the goal for a hospital, a public sector hospital, is to be in the 3 to 6% range for your total margin. And you can see 15.5% is very good. And I mentioned this in the finance committee meeting, but we work with, our primary practice is critical access hospitals. So we work with the smallest of the small critical access hospitals to some of the largest of the large critical access hospitals like Kittitas Valley Healthcare is. And the larger critical access hospitals, as a rule, are doing pretty well under the critical access hospital system, and particularly in a state of Washington that pays Medicaid well as at cost as well. You have the full service range and the benefits of some economies of scale, and then the cost-based reimbursement for Medicare and Medicaid, and across the board. Yours was definitely at the top of the peer group with a few others I saw during 2021, but 21 was generally pretty good for the larger critical access hospitals in most places, as it was for Kittitas Valley Healthcare. And then operating margin follows in line with that. Don't have a lot of non-operating revenue sources other than the Provider Relief Fund, so it follows in line with that. And you can see back in 2019 it was 4.1, and then last year with the dip because of COVID, and now back in a good place where all your growth is kind of paying off in that regard. Days cash on hand. How much cash do you have? Meaning how many days could you pay your expenses, your cash expenses with the cash on hand as of December 31st, 2021, 236 days. Would usually say that 90 days is the minimum you would want to have. And then 180 is kind of the next goal. And then after that, it's like you're building reserves for future capital needs and the flexibility to get through times when are a little tougher. Future service lines. Current ratio, strong. Compares your current assets to your current liabilities. Anything above 2 is considered good. And so very strong and very consistent too. Capital equipment expenditures, percentage of annual depreciation. This attempts to show are you replacing equipment at the same pace that you're theoretically using it up through depreciation, with anything over 100% being that your equipment additions are the same as your depreciation expense. And any 1 year is always going to be a little higher or lower than that. And that's why on the far right, you see the aggregate for the last few years. It got the wrong label on there. And I always catch those things in the presentation. You never see them until right when they're on big on a screen. But that should say 2017 to 2021 is 126. So then the aggregate over the last 5 years, it is more than 100%. And then long-term debt to net assets, your debt to equity ratio decreasing as with no additional debt, but then positive additions to net position or equity through positive bottom line. And more flexibility in what you could do in borrowing in the future if you wanted. Days in net patient accounts receivable. You can see that trend as that's going down, as back in, I think it was 2018, the Cerner conversion and a couple of years with the number being kind of high, and that's now coming down in alignment with where I think you're trying to get in your revenue cycle. The high 30s, low 40s, or anything really in the 40s is good place to be. You can see the median about half above 60 and about half below 60, so in a good spot now. This shows it a different way, and you can see with the gross days without the allowance and the contractual adjustments factored in, and you can see how it's come down a lot in the last year in a good way. Then contractual adjustment percentage, how much of a standard charge is not paid by Medicare, Medicaid, or commercial insurance payers. Just for every dollar of charge, only 59 cents is actually ultimately collected. So is that fairly consistent in the low to mid 40s through the year? That's what you expect. And then bad debt expense as a percent of net patient service revenue, fairly consistent through the years as well. A little bit of not a lot of a bump this year, but a little bit up. And then bad debt and charity as a percent of the gross revenue, which is the more traditional measure. You see not high numbers. The graph probably makes it look higher than it is because the scale is only 4, but it's not. That's a relatively low number. And that's the audit presentation. And like I think I said early on, it's an easy one to give because the financial results were great and there's no findings. So there's that, that could have been the 30-second audit presentation.
It's fun to hear it.
Yeah.
So I'm glad you went into it.
Yeah.
Have any questions for Tom or comments?
I have a comment. The star of the show is sitting at the back of the room here, Kelly Gideon, who shepherds the accounting for every dollar that comes into the organization, and also the Foundation Hospital District 2 and KCHN, in case anyone's keeping track, but extremely clean books at the end of the year. No audit adjustments, no catch up, just Kelly and her team do an amazing job of getting good information in front of us so that the board can make good decisions on real financial information.
Okay, thank you.
Thank you.
To you and Vicki. Thank you. Right. Do you have anything more for us, Tom, or is that?
That's it. Well, thanks for having us. And to add to what Julie said, our team enjoys working with your team. So the audit goes very smooth. And so that's good. It's a good indicator as well. Yeah.
One question on bad debt and charity percentage of revenue. Like what's a normal value for that?
It's a very specific, I don't know what normal, that's a hard question because you'll see everything from like 0.5% in some communities to I've been to some communities where it's 20%, it depends on the state. In the state of Washington, yours is lower on the I'd say on the lower end based on your community's demographics and where you're at with the 2% range. In 3 to 6 or 7% is probably the most typical range. You see anything under 3 is a little unusual, and seeing things over 10 is definitely unusual, particularly in the state of Washington with the charity care policies Washington hospitals have and expanded Medicaid and the service, the way healthcare is provided in our state. You're not going to see over 10% very often. So you're in the normal range and probably, I would say, the low end of the range.
Bob, I'd just like to add a comment to that. We have later today, we're going to be talking about an updated charity care policy that will increase the amount of charity and that KVH offers, and this is to comply with recent legislation by the legislator. But anyway, so that charity number likely in 2000, the new charity guidelines take effect on the 1st of July. So it's highly probable that that charity number will trend up.
All right.
Thank you.
Thank you, Tom, and thank you, Ann.
Thank you.
Thank you.
Okay, thanks everyone. Good night.
Good night.
I didn't want to waste their time, but I mean, shouldn't we? I don't know. I mean, it's wonderful to see how well this access approach is going and how, I mean, we're an independent community hospital and there are a lot of those around the country that are not faring so well. And it's just heartening to see that we're in a strong position. It's a real team approach. I just appreciate all the work that everybody in this room is doing and all the other KVH employees, and they're no finding. It just seems like we're doing everything pretty well, and it makes us look good, all this work that you guys are doing. So anyway, I mean, thank you, and we really appreciate it. I know. Anyway, this just it's really good to see this.
Agreed.
I don't know if we want to drop balloons or guys a round of applause or something, but you guys are just doing a great job. So, thank you.
Balloon drop hatch up there.
Yeah.
Dr. Vaughn.
So
So
anyway.
can I just say, financial statements like this, operations that are functioning the way operations are functioning, we know we have some challenges, but it made for a very positive and robust board strategic planning retreat last week. And I just think about what something like that would be like if you didn't have the financial strength that the expertise of Scott and Jason and their team bring to the table. It's good to be able to plan and dream and think about new access and becoming the employer of choice. Well said.
I think I mean, you're right that that credit needs to be spread around, but you thank just about everybody. So I might as well thank you as the CEO for leading the organization through what could have been some very difficult times and coming sort of through it. And I mean, we're still going through it, but in a very strong position. So anyway, I appreciate it. So thank you very much.
I mean, a few years ago, we started kind of chasing the small stuff that was kind of leaking out. I just thought that's made a big difference to go back and make sure insurance companies are paying us the right amount. Look at these different programs that Jason and Scott, his team has done, because the little things add up to big things.
And keeping more care local.
Yeah.
Something we wanted to do.
In addition to rev cycle work that you have to talk about our managers and directors in the departments also. We have people that are cost conscious individuals. The overall philosophy is to be conservative, and there's not, when I bring capital requests and things like that forward, they're needed. You know what I mean? We have and when we come and talk to Julie about FTEs, they're needed, and so it's the overall philosophy is to be conservative on our expenses and to capture as much revenue as we possibly can. And it's permeates throughout the organization. When we talk about volume, the two ladies on my left are a big reason we've got volume. And then Dr. Martin and our physicians, you know, the whole idea of access is kind of why we've got what we've got. So.
Well, I'm thankful for all the work you do and proud to be part of the organization. And it makes it really easy to do our job on the board. I think that we're not having to worry about a lot of stuff, and that there's strong leadership in the administration and strong employees on the grounds. Thank you.
All right. Moving along to Vicki Mataro, Chief Nursing Officer with Safe Staffing and Nurse Conference Committee.
So I almost feel like I should lead with an apology that I've never asked Vicki to do this presentation to the board before. This is some of the strongest work we do with our WSNA members and with our nurses. And it's so well, the participation is great, the conversation is outstanding. And I think it really is sort of the foundation for some of the very positive working relationships we've developed with our nurses. So take it away.
Great. Well, thanks. It was good to see you. Sorry I wasn't able to join you last week. I heard lots of good things. So Julie had asked me to talk a little bit about some of the nursing committees that we do here at KVH, which are mostly legislated by the Department of Health as well, and then with our union partners. The Nurse Conference Committee is strictly a committee meeting that talks about specific things related to the nursing contract. And of course, that's a 3-year agreement. There are, this year we added a couple of MOUs to cover stipends during COVID. So this committee meets quarterly and ad hoc. We've been meeting a little bit more just because of the stipend issue. And if ever any nurse has a grievance or a question about things, we may have to meet and discuss those things. So that meeting is scheduled quarterly, but like I said, it's pulled together more frequently. And it's used to foster relationships between the union, to avoid grievances, to settle things up early when we hear concerns. And it's usually between the nurse and the nursing, the staff nurse and the nursing management, to include myself, the department directors in those departments. There's 5 representatives, and these WSNA nurses are elected every 2 years by their peers. I think we can change that slide, I think, on the next one. So currently, it's more than 5, sorry. These are the membership. We have a chair and a co-chair. Then we have a nurse that meets with every new nurse in the organization to tell them a little bit about the union and what the contract entails. Secretariat, treasurer, and then a grievance officer who usually handles situations when we get formal grievances from the union. Their representative is a regional representative, and she covers more than our hospital. So she's been zooming in a lot lately. Her name is Carmen. A very good relationship with that team and with Carmen as well. Sometimes we'll just bat things off of her because a lot of them have to do with the nuances of the language in the contract. Sometimes it's perceived differently or read differently or interpreted differently. So this committee pretty much is an adjunct to the WSNA Conference Committee. However, it does not talk about contractual issues or things in the contract per se. Safe staffing was brought into, I can't remember, maybe 15 years ago, 10, through the Department of Health, that it was mandated that hospitals will have a safe staffing committee to consist of administration and nurses and nursing directors. And the purpose, as it states here, is to protect patients, support greater retention of nurses, and promote the evidence-based staffing. This committee, Safe Staffing, we're only mandated to meet every 2 months. We meet monthly, and I'm glad we do. Otherwise, issues stack up and things get, a little escalated a little higher if we don't address them quickly. I'm just going to say a little bit about nurse practice. Nurse practice has to do with nursing our scope of practice, what we're allowed to do, what's safe for patients, what is best practice in the nursing world. This has to do with workflows in the departments, and each department has its own little nuances. So we like to partner with the nurses when there's issues that come up around patient care. And they have really most of the suggestions and better, things to contribute because they're frontline and do the work. So we partner with them. Nurse practice, we combined these because it's usually the same people. And if you look at the conference committee, safe staffing and nurse practice, that's 3 committee meetings a month. And for people to commit time to that, it's really difficult to get them away from their units to do that. So we've combined these. So actually we meet monthly and address both of those issues in one meeting. And then of course the conference committee is quarterly. And I think we can go to the next slide. Maybe. Sorry about my next slide. There we go. So at the Safe Staffing Committee, we have to look at the staffing plans in each department annually and submit those into the Department of Health. We submit them annually. We have to review them every 6 months. This is just an example of the emergency department's staffing matrix. You can see it goes by hour. It starts at 7 a.m. and it goes all the way down till 7 a.m. the next day. It tells us how many RNs are on at each hour, and then how many additional staff, like we have a PCT or patient care technician and a secretary during various hours also. We have to review these, and in our plan, we have to account for what happens when our acuity goes up. How do we plan to mitigate those? What do we do when we have mental health patients? How are we going to handle those? How are we going to cover our breaks, or lunch breaks, coffee breaks, 12-hour shifts, they get 4 breaks? How are we going to mitigate those and make sure that the nurse and the patient care technicians get out for their breaks? So underneath, we have narratives on each one. Let's flip over, Mandy, to the next one. I think I put a med surge. These are a little different because it's by census. So we have a census here. We only have 13 beds. So here's our census column. And depending on what our census is, then we have 1 RN, 1 NAC, 1 secretary. So on the inpatient sides, we go by census. In the ER, you really can't do that because, well, for example, now they have 18 right now, and at noon they had 4. So you really can't say, oh, let's just staff for 10. So it gets a little tricky in those departments. It's better to control on med surg and CCU and family birthing because we can use our census and our acuity to do that. Same thing on these. We have to account for meal and rest breaks. And then any one-to-one that comes in, like mental health patients really draw in more resources. So we're having to adjust those. These plans, like I said, every 6 months we have to review them. And then if we make changes, every time we make a change, we have to submit that into the Department of Health. Any questions so far? I'm kind of just talking.
Yeah, so this is hospital nurses, clinic nurses, home health.
No, this is only WSNA nurses. So that just means those that are under the WSNA contract, which is all of the hospital nurses and home health.
Got it.
The clinic nurses are not under the union. And I've never ever worked in a clinic in my life, so I'm not sure how they staff there. That's another probably challenge.
I believe the WAC too is only for hospitals.
Yes, the staffing plans.
Regulation doesn't apply to clinics.
Right.
Thank you.
Let me see, next thing. Oh, another thing, or one of the main things we do at the safe staffing. The Department of Health and WSHA, Washington State Hospital Association, and the unions have collaborated on creating an avenue for nurses to share concerns about staffing in their hospitals. So they have a form which is called a staffing complaint form. They used to be called assignment despite objections. So we've gotten a little bit, kinder and gentler. This is where the nurse can formally submit a concern about a staffing that they have had to do, which they felt unsafe. So anytime, anywhere in the hospital, home health, the nurse, if they feel like they've had an assignment that's not safe, or they just have a concern about staffing issues, they submit this online and it goes to myself, the director, and to the union. There are certain rules around how you handle these, and it has to be discussed at the safe staffing meetings. We accept all complaints, we research all complaints, the directors do a little investigation as to what was going on at the time, how many sick calls there were, what was the census, were there any one-to-one patients, just what was going on to create that concern. The house supervisor is greatly involved in this as well because they do the day-to-day staffing. So we have to get a verbal, or we usually get a little written memo about what their part of the situation was.
What is the access title? The label's down there on the bottom.
Oh, yeah, maybe we can put that up.
Okay.
So this is for the last 3 years, the amount of complaints. I have never, and I've been here a while, I've really haven't ever had it up to 10. We're up to 10 already this year. Normally we try to mitigate these things at the time that it happened. What the nurse is supposed to do is have a discussion with the supervisor and with their director at the time and say, hey, I'm really concerned about this situation. I feel like I need more help, or I need whatever it is they need to get through their shift. When that happens, we can usually mitigate it at the time. We'll start calling, we'll start readjusting assignments, we'll float people in to help, and then we'll just start calling. And usually we can mitigate it at the time. If we cannot mitigate it at the time, and it is a terrible shift, and some shifts are just terrible, and everybody's all in their hands on it, it's still terrible. If we have done our due diligence and called everyone we absolutely could think of, if directors are in helping, if ancillary staff are in helping, those are considered resolved. At the time we tried to resolve that problem, we did everything we could. Last month, we talked about one, I think we called in 35 people. I mean, it's just, if we do our due diligence and help and try to mitigate it, then we can resolve them. It's the unresolved ones we're concerned about, or the ones that we see becoming a trend. If they become a trend, then we look at our staffing plan, and then we go to Julie and say, hey, I think we might need to adjust this, or somehow change staffing hours, bring in more people at peak hours. But that's where the great discussion comes in. No one's penalized or accused or pointed fingers, oh, I told you to call and no one called. It's everyone really tries to help do this. So we're up to 10 so far, and it's only May. But as we go to the next slide, I'm hoping we kind of look at our staffing patterns. I think I mentioned currently we have 18 WSNA openings, and we have 14 travelers. That means we've got 4 empty vacant positions currently. The travelers are wonderful. We've got great staff. However, there's a learning curve for them to catch on to our processes and all of our little nuances. So that's part of the problem. This kind of just divides the staffing complaints by departments. As you can see, ED, which is our most erratic, I guess, department, it goes from 0 to 60 in 10 minutes. And Med Surg, which has constantly been above our budgeted amounts for census. The other departments are a little more fluid. Their census kind of waxes and wanes. We also track low census, which we have had very little lately. Prior to COVID, we were way up top. Now it's just very, very rare that we have low census, but that's another thing the safe staffing looks at, because then you can look at your staffing plans. Why are we using so much low census? Do we need to look at how we staff? Do we need to shift these things around a little bit? And I think next one would be, is this close? Oh, missed meal breaks. That's another thing. We have to track when people get their breaks or don't get their breaks. This is another staff retention, staff maintaining their sanity. It's just, when the shifts get long, you need your breaks. We encourage people to get their breaks. Looks like Q1 was a little bit high, and I can tell you just without even saying the departments, it's usually ER and OB. When OB gets busy, yesterday there were 3 deliveries all within 4 hours, and today there were none. So we have to call people in, and labor nurses, if a mom is laboring, we don't like to trade them out, especially during that last phase of labor. It's uncomfortable for the patient and the nurse to leave that patient. Q2, well, we're still just in the May, so we're still looking at that. But those are things we discussed with the group as well. How can we get you to lunch? Do we need a float nurse? Do we need your manager to help that happen? And they're supposed to tell us before instead of after the shift and say, hey, I didn't get a lunch. That's where the supervisor really helps with those situations, because they can find people to help break. And what else do I have? I think that's about it. Did I miss something, Julie?
No, and I just will say, I think Vicki and her team and Manda use this as such a sincere tool for problem solving with the nurses. I think that is one reason that we have as much participation in the meeting, and then also just a strong basis to agree and disagree and move forward. But I'm always impressed when I come to this meeting that most of these things have already been resolved. So they've talked, it's like they talk in abbreviated sentences because they all know what happened. They all know what efforts were made, and it's already been resolved. So I'm kind of ashamed to say a lot of hospitals don't check the box on these committees. And I think it shows up in some of the real aggressive legislation we saw last year and in some of the relationships we see with the union. So, but Vicki sets the tone for this and does a fabulous job.
Vicki, I have a question about the missed breaks in birth center. That's an interesting phenomenon that, and I can see, how that could happen, that they've invested so much time in this relationship between nurse and birthing mama that to step out for their break or their meal might seem like an unattractive option at the time, when things are getting pretty intense. Is the thought that we won't see the needle move a whole lot on that? It's just an understood that.
No, they're very clear about the definition of breaks. A meal break is a 30-minute break. And the rest breaks are the ones that get us. They're 15 minutes. If you call someone back within 10 minutes, they miss their break.
Sorry, can you say that part again?
If you're scheduled for a 15-minute break and we call you and say, hey, something happened, you need to come back from your break early.
I see what you're saying. So 10 minutes into the break, they
Right. What happens is, and they're set times. So if they come at 7, they need to take a lunch break by 12:30. Otherwise they miss their lunch. So if you have
to get it at 1,
right,
it's a miss. They got it, but it's still considered a miss.
Yeah, they got it late.
Okay.
But they didn't get it during their time. So some of them, they'll work for like 6 hours. And granted, we can go to the restroom and we can get water. It's not like we're just never leaving the room. But that defined time away. You can't have it
Uninterrupted.
uninterrupted, right? You have to have it uninterrupted, and that's what catches us. Yeah, if we see someone who just can't step out of the room, no, that's not a thing. We do that. OR gets a little tricky too, because they'll have some long cases. They'll come on at 7, go on a case at 8, and they don't get out till 12:30. You know, they should have had a break during there, and OR, of course, we don't like to introduce people into break people, because then you're it's just that much more opportunity for infection.
Is there any room for nuance with the way the law is written as far as, I mean, that makes perfect sense that you wouldn't want to be swapping people in and out for 15 minutes here or.
Yeah, there are ways to explain that. However, this just doesn't affect nurses. This is across the board. It's technicians. It's a state law about labor and industry about breaks. They do give exceptions to healthcare workers, event of an emergency, or if it's going to affect the outcome of a patient or something, then you can certainly, explain that. And most of our staff are very good about doing that. They're more cautious about taking care of the patient than they are taking their breaks. And we have to kind of push them. It's okay, I can take care of a patient, really, I can.
Sure. Okay, thank you.
Yeah.
Good explanation.
So, quick question on the low census, like, does the house suit make that call based just?
Yeah, like today, our shifts change at 7. By 5 o'clock, we should have notified someone if we didn't need them to come in. Normally, I'll have a list of 5 people who want it.
Yeah.
So it's not difficult to call someone.
Yeah.
What's happened like today and yesterday, I had no opportunity, and I had a whole list of people, so they're.
Yeah.
It's just been really busy.
That's a tough balance.
Mhm.
Sure.
Yeah. The other questions?
Thank you so much, Vicki. Great, reports and dashboards, starting with quality, Mandy Wilson, Chief Quality Officer.
Hello. So I have a couple of my reports in the board packet, of course. I do have some updates and some things I want to talk about specifically. In my board report, I talk about seeing a slight rise in employee health calls. Those actually did go up quite a bit in May. So by the end of the month, or at this point in May, we're already seeing 84 employee health calls, so people being sick, and that's up from 35. It's almost doubled from April. We have had quite a few more positive staff, so 19 in the month of May already compared to April. And then we have had 20 different employees excluded for work because of COVID compared to just 7 in April. So we're seeing a lot more COVID in our employees.
Can you remind me, trying to keep up with the guidelines, and I know it differs a little bit for healthcare versus the general public. What drives exclusion of employees? Is it only for positive employees or exposures or?
What's different in healthcare is that it's based on our staffing. So one of the things we review in incident command every week is what our staffing level is at, whether we're at crisis, contingency, or conventional status. In contingency status, what's weird is contingency status actually matches the public's guidance for healthcare, where if we were in conventional, it'd actually be more strict. You would be out for a full 10 days if you're positive for COVID, and there's testing required if you are vaccinated, and you do have to be excluded from work if you are unvaccinated and exposed in conventional staffing levels, which that doesn't match actually the public guidance. In contingency status for healthcare, if you are positive for COVID, it actually just matches the public. 5 days at home for sure. And then if you are meeting criteria, to 5 days with a mask outside of the home. We are seeing staff that aren't able to come back after 5 days. And it runs the whole scope of things. We have had some people with no symptoms at all like none. And we have had people that are really ill and out at least 10 days back to that
And that must be
additional isolation.
so hard to forecast when you don't know what a course is going to be like and how it can change from one moment to the next.
And it doesn't seem to be dependent on vaccination status. If you're exposed, there's just more testing if required if you're not boosted or unvaccinated. Where if you're boosted, there's no testing required in your, neither of those groups are excluded from work, as long as they're asymptomatic.
Are we seeing less infection amongst boosted?
We haven't looked at that again since January. I know in January, Anna did that look at the rate of, what was it, attack rate is what it was called. And there was a difference. I don't know what that looks like now. We haven't looked at it lately, but that's a good question.
It does seem like our community is having a little bit of a uptick. I'm seeing that across various
What I
sectors.
noticed is people who've never had it are now getting it.
People who thought they were just super immune from the get-go and
Yes.
they were just lucky.
Yeah.
Maybe we.
The rest of us are
Lots of
not.
folks. Yeah, yes. Those folks that, yeah, vaccinated and never got it. But I am seeing a few more too who had infections back in fall or late or early winter. So,
One more question. Are we
Yeah.
seeing any third infections or?
Yes.
Okay, all right.
yeah. They're not as many, but there are a few.
Okay, all right, thank you.
For employees, I don't know if you're talking about patients, but I know for employees, there's not the norm. The other thing, so we still are, I'd say we go above and beyond as far as notifying employees when they take care of positive patients. But we have seen that increase, right? We've seen the ER numbers go up as far as COVID positive cases. And we have had a little bit more admissions, but I'll let Dr. Martin talks about that in his report. So he can talk more about disease burden in the communities. The other thing I just want to mention is that related to COVID and employee health, OSHA was convening to talk about making a permanent standard instead of the temporary standard they have related to COVID, which tells us things like we have to screen employees, we have to be wearing masks in healthcare. They did have their informal public hearing concluded, and they said they're going to reopen the docket for more comment. So there's been no change in what OSHA says to us and our employees about what we need to do to prevent COVID in hospitals. So we are, everyone has to mask still. We still do need to screen ourselves daily for symptoms. We need to be able to contact employee health. We need to notify employees when they're exposed. We need to have patients still be wearing masks. And like looking at this rise in numbers of calls and cases in our employees, I'm actually very thankful that we haven't changed that yet in healthcare, because I can't imagine what would happen to our staffing if we weren't wearing masks and we were at work positive and not knowing that we were sick. So I think that's really helped us. So that's, any questions about employee health?
Sort of tangentially,
Yeah.
are we seeing flu still?
Anna said the other day, it's still there, but it's definitely decreased. Not as we saw before. And we were seeing quite a lot of other respiratory illness in our employees. And that seems to be trailing off a little bit, but kind of afraid to say that. So then I just want to, I did want to go through the dashboard with you a little bit. There's some really cool things happening. I wanted to be a little bit more specific than my summary in the report. Related to sepsis, that's the top left there on your dashboard. There was a perfect case. Oh, that was not a sepsis, a stroke case TPA case in February, and Bonnie and the team is making sure they want to talk with the staff and make sure they know, they get recognition for the excellent care they gave in that case. The median time to EKG, right, we're seeing that improve, and part of the reason they've been doing in-person training. So Cody Staub, the trauma sepsis stroke coordinator, and Bonnie Gibson in my department, they've been doing audits and process walks of, what's going on when we're doing these EKGs? How can we get back down below that goal of 10? So we'll be looking to see if that continues or if that's just a blip. The blood product documentation, this is a new measure. I just want to remind you that's a new measure, but we do have all of this back data, and I think things are moving in the right direction. There's been a lot of work put into that with the lab, nursing, to get that documentation to be more accurate.
Maybe what sort of oversight or missed documentation, what would cause this number to go down?
So it's a bundle, so it's a number of things. It could be, the consent not being done beforehand. It could be the vital signs, missing one temperature on the vital signs. I'm trying to remember, there's another one there. There's another component that I can't remember off the top of my head.
Start and stop times.
Yes, start and stop times. I think there's one other.
Reaction.
Oh, yes, that's what it is. The
I
reaction.
wondered how long Stacy was going to be able to sit there.
Yeah. So if there was any sort of blood reaction, that's a piece of documentation that, so really, and a lot of work been done about giving feedback to individuals about their documentation, whether it's excellent or they need to revise, go back and complete their documentation. Sometimes we're not able to, but every unit is being reviewed.
When we say unit, we mean a unit of blood.
Yep.
Every unit given. And so there's so many factors that go into each unit, just one missing counts that as incomplete.
And then, so restraints, that there's a lot of work going into this, but we do know, January and February were very difficult staffing, very high volumes in all areas. And again, just reminding you that this is about documentation, not missing care, but if you didn't document it, it didn't happen. One of the things they're working on now and seeing is just that order being reordered by the provider. And so how can we help the provider so they don't have to remember that they're reminded to do this? Especially if you have children, they have to have the order every 2 hours. So that can be challenging. So there's lots of work going on there.
I thank you for doing that work, and I also appreciated in your report the detail you gave on the cases. That was helpful because I've often asked about this, but that helps to clear up that question in advance. So thank you.
Yes.
I have a question about one item on here. May I ask you now?
Yeah.
So I noticed that our Medicare wellness visits have started going down. Is that a staffing issue in our providers' offices that we're not doing those as much? Because we never hit the 60% level that we were talking about. And I noticed it's dropped down now to almost 30%, it looks like. So are we not offering wellness staffing to the Medicare patients now, or?
No, I'm glad you asked about that. So first of all, that 60% is a stretch goal that was made by the Washington Rural Health Collaborative for all of our rural partners about where they would like to get to. Where we're at right now, we are the best out of all the Washington Rural Health Collaborative Hospitals.
Say that again, please.
We are the best
We are the best.
out of all the Washington Rural Health Collaborative Hospitals.
Oh, that's wonderful.
So,
We're not very good.
so no, you're absolutely right. It is a staffing challenge. So usually an RN in the past would do this visit, the majority of the visit. Recently, and you can talk about this more if you'd like to, Stacy, we've added MAs into that process because they can do it as well. So it's kind of shifting. It's been very difficult to hire both RNs and MAs, but seeing how we can, who all we can use to continue to do this, because we do see it's very important. But that is part of why you're seeing the decline. But it's also, the other thing is it's that is a rolling 12 months. So it's really important that you know that it's a rolling 12 month. And if you look at the bottom there, the visits the last month, there are actually more visits in March. So that rolling 12 month, makes that line kind of flatten out. So you don't see the variation month to month as much. And the reason we do that is that's how the Washington Rural Health Collaborative measures it. But that's why we put that number on the bottom, so you could see how we're doing month to month.
I mean, the one reason I ask is when I reached the age to get Medicare, I received a phone call from my provider's office wanting me to schedule a Medicare wellness visit. But this year I did not receive one, even though I may have scheduled one myself later on. And so I was just wondering whether we're missing some of our members of our community that we should be calling them up and keeping their Medicare wellness visit up to shape, because some people may not have the ability to call in, and so we should be touching them. And I was just thinking possibly it could have been a staffing issue, because I know even last year, because of the COVID, I still received a phone call to do a Medicare wellness visit because I met the qualifications for it. And so I'm hoping that we haven't missed other people in our community that have been getting the wellness visits, but we didn't get them called this year.
I'd have to ask Stacy and Dr. Martin, that you're talking about a recall process, and I'm not sure where we're at with that.
Yeah, anyway.
Something good to look at.
Okay, well, and I'm also not whining, okay? I am not whining about it. I'm just making a comment about it, okay? Because I believe in a huge amount of transparency about different things, but that's what keeps us one of the best hospitals in the collaborative, because we are very transparent.
So 2 observations. One, this was work that was being supported when we were part of Caravan ACO. And so it's been harder for us to maintain a focus on it. And yeah, staffing is thin. The other thing I'll point out, just to Mandy's point and Dr. O'Brien's, while we haven't made that 60% mark, the green dotted line that you see well below ours is the rural collaborative average.
Oh, so we are, that you're able to show that we are truly doing better than the rural collaborative. So our Medicare patients in our community, we can actually say are weller than other Medicare patients in the rural collaborative.
But again, back to Dr. O'Brien's point, that doesn't mean there isn't room for improvement and the need for improvement. We're just starting from a better place.
Right.
And Dr. Hibbs is chomping at the bit, I think, to get that into the quality measures and the values alignment work we're doing.
So on hospice, average length of service, so our goal is 60. But how's that compared nationwide? Are we right along nationwide?
National mean right now is at about 60. Okay. What we've seen over the last several months, and Rhonda can speak to this as well, but we're seeing a lot of very short lengths of stay.
Yeah.
Like 18 hours. Our mean for the second quarter, mean length of stay was down to 31 days. The median was 13.
Can you say that one more time?
The mean length of stay ending for second quarter was 31 days. The median was 13.
What accounts for that?
We have several patients that have had really long length of stay, and the mean is skewed by outliers. It's, I don't know, the best explanation I have for short lengths of stay is delayed presentation. I'm thinking in particular of one individual who delayed seeking care because the stated goal was to care for a dying loved one. And it wasn't until after his loved one passed that he presented for his own care.
So it's not, as far as you can tell, it's not that they're being referred to hospice late because of anything that providers are doing.
No, but that being said, we are reaching out to our clinics and reminding them that the service is here. The way it's manifesting, what I'm seeing too frequently is the patient that's hospitalized and discovers a terminal process during the hospitalization and hasn't been into primary care for 12 to 18 months. Or there was something that was being monitored that the patient stopped showing up for a period of time. A fair amount of it too is recurrent illness. Somebody that had been in remission and stopped follow-up. And when they showed back up, they were really sick.
I know historically we've had problem getting patients admitted to hospice soon enough so that it doesn't become, like you said, that one patient was 13 hours before they crossed the celestial bridge. So did we have more issues, do you think, because of the COVID? Some of the patients didn't want to be around other people, even though they know they were close to crossing the celestial bridge, but they were scared of being around other people.
Yes, and one of the things that we frequently hear from patients when they're admitted to hospice is we tell them what members of the team will be coming to see them, and they say, no, please. I don't need social work. I don't want chaplaincy. I don't want to volunteer. I don't want all that traffic in my house.
Because of COVID, okay.
Yeah.
And I can think of one case where a patient's hospice diagnosis was COVID-19. And the family was apprehensive about traffic.
In reciprocal, they didn't want people to become infected from them? No.
They were worried about traffic in and out of the house.
Okay, well, thanks for the update on the hospice. Thank you.
I'll just put one other. We aren't seeing a change in the number of admissions we're doing. But we are seeing a change. Our census has been down. It's starting to trend back up. Pre-COVID, we were typically running around mid-30s for our census. At the peak of the pandemic, we were down to a census of about 17, 19. We're back up to mid-20s. But the variable hasn't been the admissions or the referrals. It's been the length of stay.
When you're talking about admissions, you're talking about strictly hospice admissions.
Starts of care.
I want to make sure to go back to the front page, to days to referral completion, because I think there was the new referral module that was implemented for CERN, which I think has helped. And then I also just want to highlight some work that Brenda and Shelley have been working on, making sure that they're looking at how those are ordered and that that's flowing correctly to and addressing any issues people are having with ordering the right referral, so it goes through that process. So they're real-time working with staff about ordering that. Let's see.
You know, a couple of these other graphs you have here, I think that maybe I always wondered whether you might want to cook the books a little bit. It's like, other than needle sticks, we only had one needle stick back in February, but it goes way up in the graph because we only do 3 needle sticks on the graph. The same with the hospital acquired infections. Do you think that makes those graphs look scary because they're bigger and we should cook the books on them a little bit?
No, I don't think we should because, well, one, we'll see some things in the next month or 2 on needle sticks. So I don't think we should change that. But also with hospital acquired infections, we've really been working hard on surgical and site infections for years. And I think it's important to see the direction that's going, how we've come, far we've come, even though the numbers are so small, right? They are gonna look, it is gonna look pretty crazy. But I think we need to see.
I think it would be neat sometime, and I'm sure I could pull up my old packets and look and compare, but years apart to see where we are at now versus.
So that's one of the things we do at Infection Control Committee is you do look year to year surveillance and infection rates, and then that goes to QI Council. Twice a year, usually Infection Control presents to QI Council to share that year over year look. And I know actually the Surgery Anesthesia Committee is looking specifically at surgical site infections. Speaking though of cooking books, the pain reassessment after medication, one of the things we have talked about is changing the scale on here so that we're looking at, the 60 to 100% so that the staff can see a little bit better kind of where that line's going when it's, the scale is that large from 0 to 100. They've been, they've been working on it. And so we did look at that at the last data share meeting together and we're going to probably, they did.
I was gonna say, that's what we're
It's
looking
in
at.
there. So we did do that before. You may recall that it was 0 to 100. It was really hard to see what was happening month to month. So hopefully that will help the teams. Is what we're doing making a difference? We wouldn't know maybe immediately, but are we on the right track? The bottom right corner.
Yeah, that makes sense to focus in on it into the appropriate range.
Right. And on page 2, I just want to point out on the left, improvement in management of work. Well, first of all, timely start for PT for home health, like great. They were at 100% within 48 hours. Considering how hard staffing is, I think we should be really proud of that. And then improvement in management of oral medications. I just want to remind you, this is a new measure. And I think they're doing some really good work there. On the, just keeping down on the left-hand side, the compliance concern reported. There should be, good, they put the dotted line in because they changed the way they counted. I don't know if you remember, but from last quarter of this year to Q1, we said, no, we don't want to just know of the claims or the concerns that were considered, yes, a true compliance concern. We want to know about any time that compliance is contacted. And so that's why it jumps up in Q1. She doesn't have the back data for being able to capture anything that was reported to her, only those that were deemed compliance concerns that she did a full investigation on. Does that make sense?
That's an interesting graph, yeah.
And then for adverse medication events, I just, one of those medication errors, the one in the clinics, just kudos to Amy Steingus and Shelley for their work with the immunization process in the clinics. They're doing really great work there. And I think I just want to point out after our retreat, and we were talking about employee reporting and our reporting culture and how we do with that. So you can see we measure both the Verge reports, so what people put into the incident reporting system, and safe board sticky notes, right? The things they're working on with their team that, where there was no harm, they want to work on together. Those are also reported, and we do have, that's right, usually over 150 a month. I was remembering correctly.
Well above goal. Nice.
To the work that they're doing on vaccines in the clinics, that's a really, really good example of, I think the initial concerns that we had and the reports that we were following were about the COVID vaccine that was being given in the clinics. And was it pediatric, should have been pediatric sort of thing. So there were a number of those things that went on. But they really took that and just took a deeper dive into how we were managing vaccines in our clinics and have just done great work, both Amy and Shelley, on not just getting the process right, but getting the folks that are doing the process competent and confident in the process now. So I think it was very intentional, very deliberate training and research. So.
Yeah, and I just, below the employee reports, the reports of occurrences, one of the things we want to look at, right, is we want to keep them reporting high, but we would hope that none of those incidents actually ever reach the patient, right? That we're catching things before they ever reach the patient. So these reports, the 5, are the number where the patient, we have a categorization, right? A harm level. And these are category D or above. And D means the patient required additional monitoring to confirm they didn't need any additional treatment. I just want you to know, so that's one of the things we look at, right? If, oh, we have tons of reporting, great. Well, did we have more harm? That would be an issue, a concern. And you can see we didn't in March. And I just want to let you know too, those 5 cases, although the patients did need additional monitoring, they all had good outcomes. There was no issues with outcomes for the patient.
Would an occurrence, I mean, would fall
Yep.
under that?
And that's that, yep.
Okay, that sort of thing. So this is a broad category of things that might go sideways.
Right, so like you could see on the adverse medication events, there were 2.
Okay.
2 of those 5 were the adverse medication events,
Oh,
right? Where they
okay.
had to be monitored because they got an, a blood glucose level was lower than we want it to ever be. But we monitored the patient, we addressed it, they ended up being okay. That still was an incident that was reported.
And it's not necessarily due to a mistake, it's just an unexpected finding.
It just depends on the individual incident. Some are true mistakes, some are the process we've designed, so. And then we do have a patient satisfaction dashboard this month for first quarter. I did look a little bit at outpatient surgery because they looked a little bit different with some of the comments, and some of that there's a little dip there. Seems to be confusion about prep for surgery or colonoscopies, confusion or frustration about COVID, whether that's testing or masking. For instance, one patient said all the employees should be wearing N95s all the time. And so I gave them my N95s, and that's not accurate. And so, or frustration with waiting when they got here in the waiting room. But other,
I'm sorry to interrupt. Speaking of frustration, the workplace violence events,
oh,
you have a note in your report.
mhm.
Remind me again, when we're talking workplace violence events, does that include between 2 employees, or is it?
Yes, it's if the reporter said that they felt, it's an OSHA definition of if they felt that they were threatened or, and so it can be verbal or physical.
Is it, okay, but are these are primarily with patients?
No,
Oh, okay. I was wondering if the security guard is helping at all.
Well, I think they're helping in the ER tremendously.
Okay.
But if they're being called to the ER, the event has already occurred. We have.
Right.
I was wondering if maybe they would stop it from escalating.
I think so.
I think their presence.
Yeah, I would just say their presence is very, they've been parked by the front entrance door, and when they do temperature checks and they ask patients to put masks on, and patients are much more compliant and willing to put a mask on when a large security guard is asking rather than some of our registration staff. So just their presence, I think, helps de-escalate things, keep things.
This measure also is one that the Washington Rural Health Collaborative has measured, and it's their definition of how you measure it. One of the things we're really concerned about was was the employee harmed, right? Because we may not be able to predict what comes in our door and how people are presenting or what's going on with them. But we would certainly want to prevent our employees from being harmed. And I think that is something we could look at, and we've been talking about on the security team is, well, is it just physical harm, or what about, emotional harm to our people don't like to be screamed at. And so I do think the security guard has helped. We haven't had, I think, as much physical harm as we had previously. I haven't looked at it in a long time, but that way, right? Like, here's when the security guard started. Do we see a difference in the physical harm?
Maybe we should tell them that even though it doesn't seem like they're doing much, that just their presence is actually creating the effect. In other words, they don't have to intervene. So they might think, well, they're not real valuable, but just their presence is valuable.
I have been very valuable. I've seen some really great interactions with the security. I've observed with them, with someone that staff were concerned about them stealing from the cafeteria or even being places they weren't. And just one interaction in particular, they were so great about asking, what do you need? And trying to make sure first that they were getting the care they needed, right? And even in like, okay, well, it sounds like you don't need to be here. It's really respectful in how they were interacting with that person. And I think that helped to make sure that they didn't escalate too, their interactions in the first place.
Okay, thank you.
Yeah.
So now that we have volunteers back in the lobby, though, when security guards are on breaks, the volunteers slide into that front desk, and we've told them they don't get any kind of firearm, taser, or anything. But it's funny to walk around the corner and see our volunteers there acting as security for that 15-minute break.
The muscle.
Yeah.
Back to the patient satisfaction dashboard, I just want to point out that almost every area we're at goal. The dotted line there at urgent care was because Press Ganey changed the wording of the question about overall care. And so we just want to be really clear that that's a change in the question now. So it may look a little bit different. I did look a little specifically at pediatrics because I saw that little dip down on likelihood to recommend. There were only 4 comments. And one comment was just that they were told they were too early when they came in 20 minutes early. But so, I don't know if that's what caused it, but fairly small numbers there. So that might be part of it. The other looking really great in family medicine, general surgery, orthopedics, family medicine, Ellensburg, internal medicine, women's health. And so that I didn't know if we did have some really nice parent service letters that I would have time. I would love to read 3 of them really quick. I'd like to give a word of thanks to Dr. Merrill Steskel for the exceptional care that he provides to my community and his patients. He takes time to listen to any concerns and thoughtfully provides suggestions and solutions to my health concerns. I always feel that he truly cares about his patients and feel confident that he follows through and does research if necessary. I have the greatest respect for him as a medical professional and a caring human being. I would like him to know that I appreciate his care. I believe he is one of the best doctors I have ever met. And then this is for the hospital, to whom it may concern. I have nothing but praise and positive compliments in regards to my recent stay at the KVH hospital, from the emergency staff, primarily Eric, to the doctors, RNs, and assisting nurses and attendants. Their professionalism was very evident, and their demeanor for the most part was courteous and at times seemingly cheerful. Considering my need for a gluten-free diet, the nutritionists and kitchen staff were top-notch and performed quite well, in my opinion, providing more than satisfactory healthy meals that I know took special preparation. Bottom line, you obviously employ great people here. Thank you. I needed the help and I feel I received the best. The last one, I would like to say a special thank you to Janae, the nurse who met with me for my Medicare wellness check. She was very professional and thorough in taking my information. She took extra time to correct some misinformation in my records. She listened carefully and was very kind and thoughtful. There was a problem with state records and immunizations given to someone else on my immunization records for the COVID vaccinations, and she found the number of someone for me to contact about the mix-up. I appreciated her demeanor and her helpful attitude. KVH is lucky to have her. We have seen that quite a few times where other places don't document their COVID vaccines correctly in ways, and it's showing up in Cerner because the interface is working. So having to help correct that.
Do we get any letters that aren't so positive?
Yes, that's on the dashboard. Actually, you can see that we get more concerns than we get compliments, but and it has gone up over the last 6 months. It's fairly typical to see it go up right around February and March when people are getting their bills and they haven't met their deductible. Yeah, and it is like clockwork each year that happens. I mean, it's not to say that there aren't legitimate concerns, and we do investigate every one of them. We have seen some really complicated cases, especially related to coding and kind of scheduling and scripting about scheduling where the patient has a perception of what they want to happen at what visit, and there's miscommunication about what type of visit we're going to have, how that's going to be coded and then billed. So
That's one of your notes near the end of your narrative, because I was going to ask about that is there any way to add clarity for the patient? I mean, obviously the patient has a certain assumption. Is there a way to mitigate that?
I think some of it
process
is being helped with what Passion's doing with the PCR, the PSR training. So really getting everyone on the same page about what type of visit. I think in some cases, the patient really is being clear about what they want, and we're not necessarily scheduling that type of visit. I think other times the patient has a different expectation, and, you know, I think it's probably getting really clear when the patient's in the room about what you're here for, and then having that discussion. I know providers really have been trying hard to be clear. Okay, well, this is the type of visit we're going to have right now. Here's what we can do today, or what we need to schedule another time. So having some of those conversations. Sometimes it doesn't make
Some of
happy no matter
what
what.
in Karen's service, you know, there's, I have regular meetings within the bar to address some of the financial concerns related to Karen's service. And there's very positive interactions and communication with patients that, you know, to recover, you know, there's opportunities, you know, where we don't communicate clearly, and we, in most instances, give the patient the benefit of the doubt. So
we're really trying hard to, in the moment, to recover that so they don't get to be a complaint. Like I talked about with the work Tony Clayton's doing, really working with Passion and those teams too, to say, gosh, when there is a mix up, how can we fix that right then, instead of waiting until they get the bill and then they're really mad and it turns into a formal grievance.
That was going to be my second comment. It feels like the just in time is being very successful.
I think so. And then we're also seeing, Brandy helps with the service recovery. So that's where we provide gift cards. You know, if there is a long wait or some sort of confusion or a mix up, that we provide those chamber gift cards to folks. We're seeing them used a lot right now in FBP with the construction and lab. And so those are dollars well spent.
Terrific.
Maybe I just wanted to tell you that I know that this took some time to get through it, but I think it's very valuable. And I really appreciate the guided tour for the dashboard this month. So thank you.
There's a lot of hard work happening by leaders and staff on some of those things. So I felt like we really need to call that out.
Yeah, I appreciate that. I hope we get to do more of that. Yeah, I like diving in and discussing. So thank you. Any other questions from you? Moving on to Chief Executive Officer Julie Peterson.
So I had a very brief report this month, but I would be happy to answer questions. I do have one thing to add, and this is sort of in preparation for an ask that I'm going to have in June. As you know, and you've heard several people talk about it today, we are members of the Washington Rural Health Collaborative. And the Rural Health Collaborative is a 501c3 organization that is made up specifically of rural public hospital districts. What the collaborative is attempting to do, and one of our strategic goals this year, is to set up a for-profit LLP under the Rural Collaborative. So what that would take is next month, it's on the back of the talking points there. Bullet number 7, in June, I will be bringing a resolution to the Board of Commissioners to authorize the formation of the Rural Collaborative LLP. So once one hospital does that, the collaborative can file the paperwork to actually establish the LLP. What that's going to allow the collaborative to do is to partner with non-public hospital districts. So the Sunnyside, Toppeniches, Tri-States, the hospitals that right now, because they're not public, are excluded from the Rural Health Collaborative. They will not be members of the board of the Rural Health Collaborative, and there are 39 rural hospitals in Washington. 23 of them are members of the collaborative. So it's the lion's share of the hospitals in the state. But it will allow us to do for-profit work. We're looking at things like brokering commodities, oxygen, liquid oxygen, things like that. So in June, I've provided you the talking points and also the presentation that the collaborative intends to do to hospitals where they're invited. And in June, I will bring the resolution to the board, hopefully to get the authorization to move forward with the LLP. The LLP will be funded by reserves of the collaborative. So about $500,000 from the collaborative will be going to fund the LLP, and each participating member will make a contribution of $2,000. So we'll just write a check for that.
So just in terms of process, you need a vote from this board.
Right.
And is the vote from this board so you can spend the money, or do they aggregate the votes of the different boards to determine, like, what's the vote for?
It's to actually authorize the creation of the organization.
Okay.
So
yeah, but I mean, obviously we can't do that ourselves. So what do they do? Is there a majority of the boards on the?
it's my understanding, we're working with an attorney who's done a number of these. It is actually the first vote that allows her to file it. All you need is one of the collaborative board members to vote, and we can move ahead. We will get 100% participation.
We function as a catalyst then.
Correct.
Okay.
That's right. So our contribution out of pocket will be about $2,000. And then every member will get a seat on the board, but that would be a board of 23. We recognize that that's an unwieldy number. So we will probably try to boil that board down to 5 voting members who receive the proxy of other hospitals.
Okay.
So I wanted to get that in front of you because it's a long resolution and I didn't want to surprise you with it next month, but in June you can anticipate that.
Do we know why this hasn't happened yet? It seems like a valuable.
It is a really valuable tool, and it's 23 people decision-making. So who meet once a month. That's right.
Okay. All right. Forward to seeing that.
The other thing I would like, you should have an original resolution in front of you for the acquisition of the property at 701 Mountain View, Ellisburg, Washington, in the amount of $356,000. Ron and I and Mandy had the opportunity to tour the building. We did, the asking price was $350,000. We did have to go a little bit above asking on that.
All right.
And you don't have any, you're not sure exactly how you're going to use this at this point.
So what has come to light through this process is this house is not ready to be occupied. So the $356,000 acquires the building and the property at the corner of Whitman and Mountain View. Ron and Scott and I will be coming to the board for a further discussion about whether it's worth investing significant amount of money to make it livable, to make it a place that we can put families or professional staff on call. So there may be an additional investment if we want to do that.
I have a motion.
Make a motion, acquisition of real estate for district purposes.
Second.
Moved by Bob and seconded by Matt. All in favor, please say aye.
Aye.
All opposed, please say nay. Passes. All right. Great. You have anything else for
I
us?
don't, but I'm happy to answer questions.
All right. I will. I'll read through it and start signing a little bit. Let's see, no other questions for Julie? Thank you, Julie.
Did Amanda have anything for us?
Oh. Amanda, out there in Zoom land, do you have anything for us tonight?
I don't have anything additional unless there's questions on my report. Thank you.
Questions? All right, thank you, Amanda. Operations, starting with Vicki Mataro, Chief Nursing Officer.
My report starts on 21. It's pretty brief as well. I'll take any questions. The only thing I need to add, the remodel in the cafeteria is to start, I believe the end of next week. Yes, after Labor Day. So that'll be a little transition, workarounds. And OB remodel is, I think, on phase 7 of 9. That's been a little, it's been going well, but it's difficult to take care of patients during a remodel. Any questions at all?
Yeah, I thought it was either phase 7 or 9.
I think it's 7 of 9.
7 of 9.
Yeah.
Okay,
We're in phase 6 of 7. So
6 and
phase
7.
7 will start next week.
And this is more of a repair than it is
Yeah.
remodeling.
Yes, refresh, repair.
So I looked up I don't know how, is it Novi? Is that the GE Novi? No. For the Birth Center, the mobile monitoring system, wireless.
Oh, yeah, yes, for OB, yes.
Yeah, I don't know why, I mean, it makes so much sense.
Right, it's so much easier for the patient.
And how soon do you think that will be available?
I don't know the answer to that.
Okay, when we have some feedback, will you
Yes.
share that with us? I'm
I
really
certainly
curious
will.
How that's gonna go, feedback from staff and from patients, I'd love to hear it.
You bet.
I don't know if anybody else had looked that up, but it looks like some patches that.
Yeah, they're not
transmit.
tethered to wires in a machine and it's more remote.
And that's Toco and heart rate in there and any other information that's gathered on?
No, I
it?
think it's the same information.
Okay,
It's just more user friendly and also for the patients, it's more comfortable. They're not tethered to a big box on the bedside.
Yeah, I wished I had that.
Yeah.
so I recall when I was having babies, it was a constant struggle keeping
keep
a
it.
baby, like, okay, we're gonna reposition that. Oh,
Yeah.
okay, heartbeat over there. Is that not an issue? Once they're
No,
placed?
I think it's once they're placed, they're more secure. That one with the belt, you move, it moves.
Oh, so that was probably my doing.
Right, the electrodes and all are a little
Okay.
easier to keep in.
Yes. Wow, what a great
Yeah.
thing. Okay, thank you.
Mhm.
Any other questions for Vicki? Moving on to Rhonda, out there on Zoom, Rhonda Holden, Chief Ancillary Officer.
Hello, everyone. In addition to my report that begins on page 22, I wanted to update you and let you know that we are now experiencing some shortage of CT contrast, just like the rest of the nation. This week, we only got an 8-day supply of what we had ordered. So we are taking steps to really try to minimize the use and make sure that it's appropriate use for contrast if patients are having CTs. And of course, the majority of those patients will probably be coming in through the ED. I did have them do a count to see what they had squirreled away and hidden in the department. And like the good little squirreler awayers they are, they did have some. So I think we've probably got about 4 weeks worth now. But this is expected to go until sometime in July.
Do we know what's driving that shortage?
The manufacturing plant in China was shut down because of COVID.
Oh, boy.
Yeah.
Okay. All right.
Other than that, I'm happy to answer any questions.
Any other questions for Rhonda?
No.
No. All right. Thank you, Rhonda.
Thank you.
And Stacy Olay, Chief of Clinic Operations.
So we have talked a little bit about staffing issues at the clinic, and we are really struggling with this. We currently have 15 MA openings. We have 9 clinic nurse openings and 4 PSR openings. And some of these go back to 2021. So we are starting to look at travelers now to fill not all of these spots, but what we deem critical to fill. So we're looking for probably 4 to 5 nurses, 4 to 5 MAs to get in as travelers and just help provide coverage. So yes, that does impact your medical wellness. It is a challenge. We just are not seeing any applicants for open positions. We do have the MA apprentices, but they're still a ways out before they could fill those roles. And I am open to any other questions.
I have a question about your chart, the first line cardiology. I was just surprised to see that an established patient days to third would be almost twice as much as a new patient. Is there any thing behind that number?
I think it is more of a mix of trying to get new patients in and established patients. So we are trying to work with her. We do have an offer out for a PA, and we can hope we can address a lot of those issues once we bring that on.
Should I be concerned though that somebody who's already established has to wait? In other words, should we be bringing on new patients when it appears by these numbers we're not addressing the current patient's needs? Or maybe I'm misreading what this chart is. I think what you're seeing is an artifact, because we reserve some slots in the cardiology schedule for ED follow-up. So typically the first appointment of every day is held out. And it may go unused, but we've done that to serve the emergency department. And is it with that chart as a new patient then? Yes. In that case? Right. So if we're holding one appointment a day, the third next available for a new patient is in 3 days. Yeah. Always. And that's structural. The third next for established patients is more reflective of actual volume and throughput. So cardiology is staying pretty busy, it sounds like. That's a gentle understatement. Okay. It's good to be busy unless you need the help.
Any other questions for Stacy? Thank you,
I
Stacy.
was just gonna say, how are you getting settled into the new position? Are you
Yes.
feeling you get the support you need and everything? And
I feel very well supported.
good.
There's definitely a steep learning curve. There's a lot of opportunity for improvement, and staff are really committed to working together, making new teams and moving forward. So it's going really well.
Great to have you on board with that. It's exciting.
All right, medical staff, Chief of Staff, Dr. Timothy O'Brien.
Yes, there's a list of 5 applications for credential new ones and 3-week renewals. You have the list, and the medical executive committee has recommended that you approve these credentialing requests.
So I would move to approve the credentialing request for this month.
I second. I do have one quick question, and Dr. O'Brien and I have been in contact about this, so I just want to be clear.
Yeah, bring it up.
Yeah, so at one point, I know that we had this discussion about whether someone had to be board certified, and the idea was, no, that's too high a standard, and not everyone is board certified, including someone who's close to retirement, maybe, who's still a good doctor. Then I think I lost track of where we were on whether the person had to be board eligible, or if that was unnecessary, or so. Would you mind, Dr. O'Brien, just sort of laying out where the MEC is on this?
Yes, did you get my email?
I did,
Yeah,
yeah.
okay, yeah. It's,
I appreciate it, by the way, thank you.
sure. I'd like to explain it because it's, when this policy was put in, that they, specialists or had to have either board certification or board eligibility. At that time, board eligibility was pretty much a lifetime qualification after completing the certified residency. In other words, you could take you're board eligible, you can take it the next year, or you can take it 20 years. However, the boards since then have started expiring those board eligibilities. So limiting the time period during which you can do your certification. So our attitude is practical approach has been they had a certified residency that they satisfactorily completed, have been in practice successfully without any major issues. And have kept up with their CME. These are the exact same requirements that some payers require in order to pay. So it comes down to, are you better off hiring this person or going without that service?
And let's just, so the medical staff requirements and employment expectations are different or can be.
The other thing, since this policy was created, is the concept of board eligibility more recently has been construed as the window of time between when you finish your residency and when you get the letter from the board saying, congratulations, you passed for your specialty. Some specialties, family medicine among them, no longer permit the use of the term board eligible. So a new family medicine resident graduating may not get I sat for boards 2 weeks after I graduated residency, and I started practice 2 weeks after that, but I wasn't board certified for another 3 months because I didn't have a letter. So I think there's some elements in the policy as written that need to be readdressed.
Yes.
Okay, I was just trying to wrap my mind around this.
Yeah.
This stuff, because I remember, I mean, we've had this conversation. So I understand that we've
We
had
may
it.
have had this same conversation 2 years ago. When we credentialed this provider.
Yeah.
I seem to remember some
Yeah, you have a little
discussing
over
this exact subject.
Yeah, okay, I mean, if you guys are, I mean, it makes sense, this idea that board eligibility would expire or something.
Yeah, see, when our policy was originally made, to be board eligible, meant that you finished a certified residence and satisfactory. It no longer means that.
Okay, so the standards are not changing. What's changing is just
Definitions.
what we call meeting those standards. Is that the idea?
And then I know we spoke about this, it's been a couple years now, but does evidence show that there are better outcomes with board certified versus?
Statistically, I don't think that statistics apply to this situation.
I don't know that those studies have ever been done.
Yeah, yeah, what difference would it make if an average was this, you know, maybe one group was a little bit better on the average, whatever, in whatever measure you figured out. But each individual is far more important.
Right, but there's no
What
body.
is this
that's-
individual's work history and success? And
There's,
it's far more important than what the average of that group is.
so there's no body that you know of that has expressed findings indicating that it's obviously far more superior or.
Every board will say that's true if there's
Therefore,
certification.
Scientific findings, let's say that.
If the study has ever been done, and I'm not aware that it has, I will guarantee you that the funding was from a board
I
to
got
prove the
you.
value of their certification.
Yeah.
Is it like the Better Business Bureau of Medicine?
If the Better Business Bureau requires you to pay $1,000 a year to stay listed, yes.
Gotcha.
Okay, well, anyway, I appreciate the clarification.
Yeah.
I just thought it would be good to bring it out
to review it again,
in
yeah.
front of the board, just so everybody's aware of this. I wasn't sure if it was a change or what, but this, your explanation makes sense to me.
And Kevin is right, we need to rephrase our policy regarding this.
Okay, and everybody's all right with that on the board?
Yeah, yeah.
Okay, well, we've had a motion in a second, so I think.
All right, call for a vote here. All in favor of the credentialing as written, please say aye.
Aye.
All opposed, say nay. Passes. All right, thank you.
And I have one more thing about policy revisions as we're going through. You people get copies of this?
In the board packet.
Yes.
Okay, and did you get the colored changes?
Yeah.
Great, because some copies of this don't have any color. Does anybody have any questions about any of these changes? Or policy for medical staff organization and function?
What was the overall purpose of these changes? Just to clean up some language and
Yeah, and just kind of adapting the language to more current realities and circumstances for the most part. And the MEC actually reviewed this 2 different months. After one discussion, it was tabled, and then the next month, another discussion. And this is how it ended up.
And the only thing that it really affects, I think, you guys had a lot of good conversations with this on MEC. But on page 28, the peer review policy, it's just, it doesn't come to the board anymore. It's taken care of by QI council. And, you know, we have representatives on QI councils. I mean, that's the only thing I think that really affects us. Eddie. But I'm supportive, so I'll vote to approve it.
All right. For a second.
Second.
All right, and moved by Matt and seconded by Bob. All in favor?
quick discussion. I just want to follow up on what Matt just said.
Sure.
So like we just approved the 5 credential. Are you saying this no longer would come to us? Is this?
No.
No, that's a peer review. Yeah,
Peer review. Okay. Thank you. Just wanted to-
Peer review.
All in favor, please say aye.
Aye.
Opposed, please say nay. Passes. All right. Do you have anything else for us? Dr.
Thank
Bryant?
you. No, that's good.
Thank you.
Thanks for the response in the email and also explaining it.
Sure, yeah.
Chief Medical Officer, Dr. Kevin Martin.
My brief report is in front of you on page 32. I would update a couple of things. One, since this went to press, we have made an offer that has been accepted for a PA to work in cardiology. The other update, or the other, update. In my COVID-19 update, I state locally cases have been stable at just under 100 per 100,000 population since I wrote that, but that number has gone up to 141. So 50% increase in the last 10 days or so in Kittitas County.
And that's just people reporting into the system. So the number could be higher behind the scenes of people that don't officially report.
It's interesting because what we've heard from public health is a fair number of folks in Kittitas will actually call and self-report a positive test. But yes, heaven only knows how many unreported positives there are that are sitting on a toilet somewhere.
Or potentially without symptoms and not even aware that they're.
Exactly right. What we have seen, again, since this went to press, if you look at the last chart that I gave you on page 34, that magenta line was trending up. That slope is unchanged. And since this went to press, that number has gone from 7.1 hospitalizations over 7 days per 100,000 population to just over 10. So again, about a 50% increase in hospital utilization statewide. There's any number of metrics that we look at. The DOH has a great dashboard that a few weeks ago was cause for hope and celebration, and now it's an exercise in red and orange. Most of the states and most of the counties in the state are over 100 cases per 100,000 population at this point, over 14 days. To put it in perspective, at the peak of Omicron in Kittitas County, we had something like 2,200 per 100,000 over 14 days. So the numbers are nowhere near that level, but it is still present and it is still going to impact hospital operations.
Back when testing was not so widely available in a consumer level, we used to be able to see hospitalizations as a percentage of cases, which was somewhat representative of infections, but now that seems to be a lot harder to determine.
Correct. We just can't get the denominator. We don't know how many tests are done, and we don't know how many positive test results there are. The one fairly solid data point we have access to is hospital admissions.
Are they still looking at some variants to see what variants are floating around? I haven't seen that much discussion about that anymore.
Currently, as of late last week or early this week, showing that my time sense is COVID fatality. But BA 2.12.1, which is an Omicron subvariant, it was accounting for 58% of the cases nationally and has become the dominant subvariant, replacing its ancestor BA2. We still don't think that we're seeing much change in virulence, but with BA 2.12.1, we think that we're seeing a transmission rate comparable to measles, which heretofore has been the single most contagious illness known to man. So records are made to be broken.
Yeah, I've had a lot of people talk to me about the monkey pox based upon when they're getting their COVID shots I've been giving to them. And I've been telling them information that it looks like if you were young, old enough that you got a smallpox vaccine, that you would be protected from the monkeypox, and that it made them very happy because a lot of people out there concerned that the monkeypox would become the new COVID, and it's not.
So there's a lot of differences, and I won't take the board's time with going into a lot of the biology except to say that most of the pox viruses are DNA viruses, so their genome is much more stable. They don't mutate the way RNA viruses like coronavirus do. And so that's why you can get some relative protection from a smallpox vaccination against monkeypox. They're related viruses and they're very stable. Unlike influenza, unlike coronavirus.
Oh, okay, all right, that was,
And also monkeypox is generally a self-limited mild illness.
yeah, but it's nice to know about the stability of the poxes, that they just are relatives, but they're not really that different.
Yeah, I've read about it. It's transmitted only by close physical contact.
Okay,
I read somewhere that the threat to the general public is low, but I feel like I heard that somewhere before a couple of years ago. So this one hopefully will stay low. All right. Do you have anything else for us, Dr. Martin?
That's all. I'll take any other questions.
You tease us with the additional 10 applications pending for next month. Are those reappointments or new appointments?
That number has actually gone up a lot. ONRAD is in the process of onboarding 17 new radiologists that will be coming through next month or the following. The bulk of those are new appointments that are in process. I don't know the exact numbers off the top of my head.
Right, but it's basically on, right?
Yeah, it's not filling some of these hard to wider positions.
Yeah. There's a couple of other specialties that I thought I was going to be bringing forward, including one candidate that MEC actually voted on that we subsequently withdrew our offer when we went through our HR checks. That's it. Fair enough.
All right. Thank you very much. Chief Financial Officer Scott Olander.
Well, thank you. As I like to do, I do like to start with our stats on 38 and the I used to go down and talk to Vicki Mataro in her office, and I questioned why is the census 6? Why is the census 7? What are the transfers are? And when I visit Vicki's office now, I'm wondering, how are we staying at 13? How are we staying at 12? And how are we? And I think John, one of the things that Vicki and I had talked about today, and there's multiple factors, but I think having a cardiologist in town is contributing to doctors being comfortable keeping a patient with heart symptoms in town. And so, these additional providers that you are bringing on, and it's the hospitalists, it's cardiologists. They're just multiple factors, but we are busier, and we are seeing it.
I've heard anecdotally that these hospitalists are more prone to keep people rather than transfer them out or too much worry about them.
I think Dr. Martin's also worked on protocols to transition patients from ED to hospital medicine a little more easily.
So it's multifactorial. And our transfer rates are down. It's also a bit of a culture change and a sea change. We're taken seriously when we talk about the importance of providing care locally.
So anyway, this is obviously impacting the finances for the organization.
I'll just say, I stepped into the afternoon environmental services huddle at about 4 o'clock, and Zamet was starting a case and so was Petty. They were both still in the OR. So
So very good stats, as you can see from just about top to bottom. Lines 1 and 2, admissions and patient days. Deliveries continue to be solid and above budget. ER has been very busy. Clinic visits down on lines 25, 26, 27, and subtotal up to 28. It continues to be busy. So the stats support the financial results that we are seeing. And so if you'll move over to page 40, is the revenue expenses. And so we were ahead of budget for inpatient revenue by almost $675,000. And the significance of that is we are compensated at a higher rate for inpatient care than outpatient care. And so that is a positive trend. Outpatient revenue was below budget. Clinic revenue was ahead of budget. And our contractuals, even though we are ahead of budget on the monthly revenue, we are below budget on contractual adjustments because of being paid at a higher rate. So this was a good month for KVH. Down on the expenses, though, salaries are our typical salary number that I bring to you each month is about $4.3 million in salaries per month. This month, we had the retention payment of about $1.3 million. So that is why, it's a higher number. In spite of that higher number, we were able to post a $71,000 operating income for the month. And then the non-operating revenue is related to unrealized losses on the investments that we have. And then as Tom had talked about that $2.2 million, there's funds that will flow through that non-operating line at the end of the year to offset some of this negative that we have. So anyway, we have year-to-date for operating income, 1.6 million versus a budget of 1.5. A net income at 510,000 versus a budget of 1.6. So all in all, a pretty good month for April. Our days cash on hand decreased by about 13 days for the month. We had 3 payrolls in the month of April, and the last one being April 29th. And we also had the retention payment that was paid. So that's the reason for the change. But good financials. And then if you look back over to page 39, you can see the payer mix, the days accounts receivable, and basically good trends for everything. So good month to be a CFO here at KVH.
Every month's a good month.
Unfortunate so far, but on Mitchell's report is on page 43. He continues to be working on grant applications diligently. Gets more excited to report big payments that come in, and I don't have anything like that to report this month, but there will be some months coming in the coming future to have to reporting some significant grant income for either KVH or KCH Ed or the foundation or something, but actively working. We do have questions related to financials for April. Okay. We have some 2 large capital requests that the Finance Committee reviewed. One is related to the PACS image archiving communication system that is used by all of our imaging modalities. And our existing PACS is nearing the end of life. It is not an end of life yet. It will be at end of life fully depreciated in 2023. but there is some software related to Microsoft that is causing us to need to upgrade this a little sooner. And the upgrade will take about 9 months. So by the time if you approve this purchase of the packs, by the time this is fully implemented and we start to capitalize this, the other pack system will be fully depreciated. So this is critical for doctors, and they compare stored images for previous CT or previous X-ray or something like that to provide patient care. So this is another tool for patient care that is critical to purchase.
And this also includes the cardiology.
It includes cardiology and mammography, so it'll cover.
It sounds like Dr. Hoppy will be pleased with this.
This will make her life easier, but not right away. It has to be fully implemented.
I think it would go live in February of next year, if I understood correctly.
I believe that's correct.
Cardiology portion.
I think so.
Don't hold me to it, but that's, yeah.
Rhonda should be able to answer that question.
Yes, that was the plan, February. Start implementation in October of 22 and go live in February of 23 for cardiology.
We have a long tradition of doing all of this on February 12th every year. So
It was Jeff's request.
And I think too, they gave me a demonstration of the system, and it was interesting to see how they currently have to measure some scans that the provider can't necessarily physically do it, him or herself, so it's just a lot of inefficiencies along with the expiring software, make it clear that it's something very necessary and important. It'll free up a lot of time from the providers, will lean towards long-term cloud storage, which will make accessibility a lot easier, redundant backups and stuff like that. So yeah, and Rhonda, thank you for being part of that tour. It was very helpful to see it firsthand, and Kimmy and Jason and stuff going through that. So yeah.
We sure appreciated your visit. Thank you for taking the time.
Yes, happy to do it. So, so I would make a motion to approve this expenditure if there's
point of discussion. You have a second if you want.
Second.
Okay, moved by John, seconded by Matt.
So last time when we got the new PAC system, radiology had a lot of issues, right? Integrating, which ended up being was that GE's issue or was that Cerner's issue?
all of the above. It was, and then there was Vaso, who was a consultant on top of that.
Okay.
So we've had a number of conversations about how this conversion, why this conversion is not going to look like the last conversion. So, yeah, I think Rhonda in particular has some PTSD left over from that. So some very careful planning to make sure that that's not the case this time.
It was kind of explained too that in 2017, they showed us one toy and then sold us something different, which caused ongoing frustrations for the staff trying to make it work. So.
Okay, thanks.
All right. All in favor of approving, please say aye.
Aye.
Opposed, please say nay. Passes. Great. And then
Thank you.
Thank you very much. Our next capital request is for some additional IT storage, and that creates backup and redundancy. And Jeff is online with us, and I would appreciate his comments. And
sure, yeah, we'll do that. So really what we're looking for is to move forward with a couple of things that we've seen in the past. And so through, and I'm going to talk about a few things. So as we've seen with our security risk assessments, our disaster recovery, DR, our business continuity, and really cybersecurity, all those things are kind of lumped together. What we're looking to create is a backup solution that it has redundancy in it. So there'll be two sets of backups. that will be done. So what we're purchasing is identical equipment that will be located in 2 separate locations. One at the primary data center on the roof and the other one at Radio Hill. The primary data center will be still at the hospital, and the secondary will be at Radio Hill. This will give us information, our data in 2 locations, exact information. And the reason for the duplicate equipment is it's the easiest to integrate and move those backups from one pair of equipment over to the other. With this is also entangled all of our VDI and single sign-on. So as you hear us about badge tap and being able to move that project forward, that also needs some redundancy. So if some of the servers go down in one location, the other servers at the secondary location will pick that up. And so that should be a seamless transition for users badging in and out of the system. So any type of disruption in that equipment obviously can cause some challenges trying to get into the computers, into the workstations. What else? This equipment and some of the software applications that we're getting will also create a third environment, a third copy of our backups into what we call an immutable environment. And so that's an area that is protected from ransomware moving forward. And so as the ransomware moves through your network, basically about every 8 seconds, it can jump from one computer to another. This environment will be segregated outside of that, so it cannot be transmitted into that environment. So in the case of any type of ransomware attacks that we may need to be, recover from, we would have a set of backups that were untouched by the ransomware. So a lot of things going on in all of this equipment that we're trying to propose. So any questions?
And Jeff, did you say that in the next 6 to 12 months or so with this upgrade, we'd have potentially a couple hundred of these badge tap workstations up and running? Did I understand that correctly when we talked about it?
Yeah, so we're looking at about 100 to be the first fully deployed and see where we're at. We have one workstation currently in IT that is kind of our testing ground to just get this going. We have to go through every application that we have on the clinical side to make sure that when they do badge tap, it's badging into all of those applications in the background seamlessly. And when they badge in and out from one workstation to another, that secondary workstation then picks up all of that same information. So once we perfect that here shortly, we'll move that into a clinical area. And I think we talked about, maybe family birthplace to be the first of that, where it's a little bit more controlled from the chaos, and to perfect it at that location. And then we'll move forward. Most of the locations that will get it will be locations where a user really doesn't have a primary workstation, right? And they're moving back and forth. So for somebody in the office that is just, the one person, they go into their office, that's not our primary focus. It's the areas where people are transitioning between rooms, between departments, is kind of where our first goal is. So.
Thank you.
Yep.
Great. Any other questions for Jeff, or can you have a motion?
I'll make a motion, we IT backup storage equipment.
I second.
Moved by Bob and seconded by Terry. All in favor, please say aye.
Aye.
Aye. Opposed, please say nay. Passes. All right.
Thank you, guys.
Thank you very much.
Thank you.
And the last item for me is I sent you an email with, and I have passed it also. This is a update to KVH's financial assistance policy. And there's The policy is the policy is the first few pages, and then the last page is the new sliding fee schedule. And then there's a separate sheet of paper that has our KVH's current, it says 2022 sliding fee schedule. And our discounts currently start at 120% of the, there's an 80% discount if you're at federally poverty level. This is needed because the legislature passed a requirement that they have a uniform charity care policy for basically all hospitals of our size, and this is consistent with that. And then even larger hospitals are required to go up to 400% of the FPL. So ours stops at 300%, and so that if you're at above 301% of the FPL, you will not receive a discount, but larger hospitals are still required to give it even more. So this is a policy that basically needs to, will be implemented the 1st of July as per the legislature. And, this is the revision is an effort to comply with new state laws and requirements.
So I remember when we were looking at the auditor's report, they talked about bad debt and charity here. So this is really good about explaining the process. On your end, like, because I'm not familiar with the actual sort of nuts and bolts of the financing. Is this something that is reimbursed at all, or do we just eat it? I mean, by like a state or federal government or anything like that.
The 65% of what the charity for Medicare related patients for hospital services or services in the rural health clinic is reimbursable bad debt. But for anything else, and that's about 40% of our overall gross revenue. For everything else, it's we have to eat it.
Okay. Thank you.
And that's going to change the landscape a lot for charity care here, it looks like, because
Yeah.
starting at 200%, whereas 200% was up already.
It has the potential to adversely affect us.
But like you said, it's required.
If somebody is eligible for Medicaid but does not apply,
They would not be eligible.
they would not be eligible for charity care if they're not taking advantage of the
Correct.
opportunities. Okay.
They have to work with us too. This is provided at last resort.
Okay.
I think we should educate ourselves a little bit though, because as the law is written, it actually applies to people with high deductible plans also.
Well, yes, it's.
In other words, it doesn't mean you don't have insurance.
Right, right.
And so there's some nuances I think need to be sussed out of this to educate ourselves as to what it may.
It's based on your income and with whether you have a high deductible plan or no insurance or.
All right. Looks like we'll need a vote on this. So.
Are we voting on this?
Discussion. It's got 2 stars.
I do. If I would have liked to give you more time, but so I do need.
Well, I pointed out to Scott earlier that I have some things we want to look at in this document. So I personally would not vote in favor of this document until a couple of those points are addressed.
Which is what, like what?
For example, the law requires the hospital to overtly state whether or not assets are included in any calculation. We're addressing it by not saying anything about it. And I feel we would want to talk about whether or not we make an official statement on that. Scott had mentioned to me when I brought it up, that because of how the finances of a hospital work, it may not be appropriate for us to address the asset, but it's a real thing to talk about. And again, you don't want to not talk about it because then the decision's made for you.
So you're saying in the case that somebody has maybe no income, but has a tremendous amount of assets?
Jeff Bezos, a few years ago, got the child tax credit, even though he at the time was worth, $150 billion. So so that is exactly what I'm saying, is there's more than one way to determine resources. I just think we should have an official policy on it. To me, that comes out of the discussion. I wanted to educate myself more by talking to Scott in the next few business days to understand, because we were crunched for the meeting, because I don't know everything about it. But when you read the new law, there are some things we're not yet addressing in this document. That's what I'm saying.
Sure.
And I feel we'd want to go through that new law and correlate things the law is requesting into our policy.
Does the law specify who determines assets or how that process?
The hospital has to make the determination and state it.
So they would request, the hospital would request asset statement from a patient.
It is an option, a path the hospital can take if they choose. But again, like Scott was starting to educate me on, it creates a different problem for us. So we may not want to follow that path.
A framework of how to.
Part of what happened with, and we addressed this a year ago when we renewed our application with the, what's the program that allows you to, it's related to physicians, and you can forgive debt if you're a physician shortage area.
National Health Service Board.
National, when we were renewing our status with them, their requirement in our charity care policy was that we would not look at assets, and we agreed to that. And so that was the reasons that although you can, per state law, you can look at assets, we will not, and we cannot, because we have told the feds that we wouldn't.
I'm sorry, Scott, could you just please repeat? You say we agreed, who's the we again?
KVH, the hospital agreed by re-upping with this program.
With which program?
National Health Service Corp.
National Health Service.
Right, thank you.
So if an individual has a lot of assets, like you're talking about the gentleman that owns Amazon, I would anticipate that he would also have a very high insurance that would pay for his healthcare, that he wouldn't have to go into looking for charity care.
I was merely pointing out that he, in essence, met the requirements. Not that he would need it, but the way it's currently written, he would meet the requirements potentially for charity care. So,
Yeah, I understand. And you're saying we, even if we eventually decide not to ask this, that we should have a conversation about it. Is that the idea?
or formally put a statement in to address it, since it is in the law itself. It has a paragraph about assets and that the hospital has to determine their policy.
Yeah, so we should either say yes or no in the document, is what you're saying.
Because the other thing is, when we get into determination, there's gross, there's adjusted gross, there's modified, there's different, what is the income? All this ties back to the last two sections of the new law. Specifically talk about for the next few years, they're going to track and they're going to require a report, I think in 2027, because of this new law, how many people change to a high deductible plan because their income falls within a range.
Unintended consequences.
Exactly. They're looking at unintended consequences, because there is a path, if you strategize, that you can actually earn a pretty decent income, have insurance, have high deductible insurance, and still meet the numbers to get a fairly significant discount on your health care. And again, I'm not saying that's a good thing or a bad thing. I'm just saying if people find out Domino's is giving away free pizzas, word is going to spread how to get that free pizza. So I just think as a group, since we're here to protect the financial interest of the hospital, that we work through what this may mean for us. And if there's any way we can.
I mean, I was thinking, if you got a kid going to school here, why would you cover them on your insurance when they're here? Maybe even working part-time, their healthcare is gonna be covered. Right?
Yeah, it's the same thing we all do with our taxes. You look at the tax law and then you start to move things to optimize, or in this case, minimize your tax obligation. It's within the law. You're not a bad person for doing that. This is a new law that has ramifications that I don't know that the people that wrote the law fully understood potentially what it may mean to a small hospital that lives on a fairly thin margin. And because what it makes you want to do at the end of the year is say, okay, this is the charity care we gave away because of this law, and send a bill to Olympia. Now, obviously, they laugh at not pay it, but it's one of these things where we don't have a lot to spare. And potentially, because it's not just the uninsured, that's the problem. Just the uninsured, it's only 2 or 3% of our business. But the problem is when you read the law, it has nothing to do with whether you're insured or not insured. It's what your obligation is and how much money you've made. And then figuring out how are we determining that. And again, I think they've got all these things that can, I believe it's any one of these puts you in this category. You don't have to have all of these things, pay stubs, W-2, Social Security, Apple Health.
We would, it says we may consider, they need to provide documentation, sufficient documentation of their household circumstances. And if it's not telling the whole story, we actually reach back out to them and ask for we can actually request additional documentation.
But I believe if one of their children was on Apple Health, isn't that document enough to trigger this? Again, when I read the law, it said that if you've qualified for one of these other things, you've already done your due diligence. And I don't know if the hospital can go above that, because they use the term like you can't punish somebody for requesting this care and asking for additional documentation when the state has already determined there's certain thresholds of income.
Well, if the child is on Apple Health, we know we'll be paid at Medicaid rates for.
No, but I'm saying one of the adults might not be on Apple Health. I'm just, again, the way the law has enough vagueness to it, it just makes me nervous that there's going to be these unexpected things. And again, maybe I'm just paranoid, maybe it has no relevance, but I don't know if people understand how drastic this change is for a small hospital that has small margins to begin with. Once word spreads as to how you can strategize your life to not have to pay your portion of a hospital bill when it arrives. And again, I'm not saying I want people to get health care. I wish we were a country that we didn't have to do any of this. But my job as a commissioner is just to make sure we don't get caught off guard with unexpected expenses.
See, we're thinking, like when people at the benefits enrollment season and they're looking for their packet and looking at the prices of their premiums.
Once you're told you can take out insurance that you're, out of pocket caps at $17,000 a year, whatever it is for a small family. And because word will spread, I guarantee it, word will spread once somebody understands how this works.
Well, we have a charity care policy as it stands.
It's not nearly this little.
We do, but as Erica pointed out, what used to be kind of the high end is now almost the starting point for some of the care.
Right, but the idea is someone could play the system, could play the existing system.
But the difference is the old system really was focused on you don't have insurance. And
So I'm not, charity care is always applied to patient portion as well. So that's not going to change. It all of a sudden is going to be worthwhile. So I don't think the triggers for qualifying have changed. And it does apply, it currently applies to patient portion, not just uninsured. But I mean, between 0 and 200%, we're writing all of it off. Previously, I think 200% was 25%.
What Julie said, we are writing that off, but they have to proactively reach out to us, provide supporting documentation. It's not just it's they do have to support the financial need. So it's.
Okay, so it's a final example, and I'll be quiet. If they have high deductible insurance and say $10,000 is going to come out of their pocket, and a family of four makes less than $83,250 a year, KVH would eat half of that,
Yeah.
5,000 out of that 10,000 they'd owe. So again, it's just, the incentive is to help make sure people had insurance and get them on insurance. But now, it's again, the unintended is the high deductible plan. And they knew it enough to write it into the law to say, we need to study this, because if we see people jumping ship the high deductible plans so they don't have to pay their portion of the bill, we'll revisit in 2027 and see if we need to make an adjustment to this law.
It's a long time away.
Well, let's, so a couple of questions. First, is this time sensitive? And second, if we notice a trend like that where people are taking advantage of, could we revisit the policy?
No.
No?
You're following the law.
Well, I know we have to follow the law, but like with, like John said, like, let's say we voted on this, and then later on we said, well, all these people who are owning $2 million houses are coming in and they have no income. Could we say, all right, we're going to start asking for assets and change this policy?
We would have to change our relationship with the National Health Services Court in order to do that. And that's possible. It could be revised if we wanted to do an asset check at some point, we could do that because the law allows it.
But we would have to change the relationship.
How difficult would that pivot be if we decided we needed to implement it?
I think it could be done relatively quickly. We'd have to, like I say, change that relationship. And that's just
Does that cost us something, changing that
Yes.
relationship?
Yes.
So that has its own.
So any providers that we have that are beneficiaries of federal monies for loan repayment, because they're working in an underserved community, we would no longer be eligible, and they would no longer be eligible.
And that's an enticement to get people.
that allows us,
here.
it helps recruit physicians to our area.
And if we have providers that are benefiting from it, we've just hit their bottom line directly.
It sounds then like, I mean, at least on that point, we don't want to ask about assets. I mean, what would we change?
So can so the way I think what this does is, by and large, it changes the relationship with the federal poverty guidelines and the percentage that we have to write off. That is what the whole tug of war in the legislature was that percentages. The Hospital Association spent a lot of time trying to lower the federal poverty guideline or stop the point at which we had to give charity care in rural communities, because 400% of the federal poverty guideline is well above the median household income in most rural communities. So you essentially just covered the entire community for free. So they did carve this out. So, and it's this bizarre, it looks like a gerrymandered congressional district. It's system hospitals or rural hospitals owned by a system, or rural hospitals with more than 55 beds. I mean, they went through this very patchwork thing to identify the hospitals they actually want to be providing charity care at 400% of the poverty guideline. So that's where the focus was. We made the point throughout the entire legislative session that you were disincentivizing people from getting on the exchange. We think that this was having, to your point, exactly the opposite effect, because charity care is about hospital care and catastrophic care. It doesn't get you in the door to a primary care. It doesn't get care established for you. It doesn't make you a patient in a system. So it is, as Scott said, the resource of last resort. You have to prove you've worked with our folks to get on Apple Care, to get on whatever other programs are out there. You have to proactively work with us to find other coverage before we're obligated to write it off as charity. And if you just walk away and say, I don't have time for this, it goes to bad debt. So
they wanted to fix it. They would have expanded Apple Care.
Right.
right? They're wanting to pass some of this.
Well, this law actually emerged from a legislator whose son was in a catastrophic car accident, went to one facility. This is the story they told when the bill was presented. Went to one facility and didn't have to pay anything because their policy, said that they were different than the next hospital he went to, which sent him to collections because they had a lower threshold for charity care. So this started as an attempt to make it predictable for patients. So anywhere they knew they went, if they'd already qualified for charity care, they know that they would qualify someplace else. That was the intent. It had unintended consequences, as you might imagine. So
So I just want to make sure the board is aware there's stuff we'll have to revisit, I think, as the months go by and just see. If it,
what does the rigor around trying to get them qualified for programs look like? I mean,
but that's the problem is if you have insurance, but it's high deductible, you still can easily meet this qualification. That's the flaw.
As I heard, but that's the case now.
right. Just at a
Well, but it's going to do a
lower
range that's normal salaries for this guy.
Write off a lot more now than we would have.
for a lot more people.
But the law requires it. I mean, so I don't know, I'm sort of thinking about where our wiggle room is. We can't ask for assets, we can't change like who's getting it. We're not changing anything about whether you have to have insurance or not. I don't know what else we would, I mean, and maybe this is a lack of my imagination, but I'm not sure what else we would need to tweak.
I guess maybe the balance is how much it affects the bottom line of providers who participate in the program versus how much we're losing if it becomes an issue.
Yeah, I would not want to hamstring our recruitment efforts.
Well, again, I don't think it's going to be assets so much as it is high deductible plans. It's not people are wealthy, it's just they've been told your first $5,000 or $7,000 or $10,000 will be paid by the hospital if you structure it this way.
Back to your point of people figure out how to game this though, and they choose a high deductible plan, they might be less inclined to do so if they know that their assets prevent them from utilizing this.
But you can exclude your house, 2 cars. I mean, there's a bunch of exclusions. If you're going to do an asset.
And quite honestly, currently, we don't look at assets now and never looked at homes, never looked at, there was.
I was picking an extreme example of how poorly this law, I think, was written. But I think average workers in this community will easily meet this threshold.
Although I think that some of the assets would be terrible to look at. If you have a house that's worth $2 million and other than that, you don't have anything else, and we look at their assets and we see that they're $2 million, we don't expect them to sell their house.
No, but there are, I mean, investment portfolios, that sort of thing.
But that's not, I mean, we were just talking about how that would be a bad idea.
Scott, have you ever worked in an organization that looked at assets? I have not.
I haven't either.
You end up in court.
But we have the law pressuring us on one side. It's not changing. It's not saying that people with insurance and high deductibles now can do it because they could do it. I mean, they could do it under the current policy, not just under this new policy. And I understand that the numbers are moving, but that's because of the state law. And we don't want to ask for assets.
Right.
So I'm just trying to think like what we would change if we wanted to.
Well, I think if it becomes an issue, it's starting to gather evidence during the next legislative term, try to provide, kind of like they did for the LEAD program that they kicked 18 months down the road once they realized that it was written very poorly. Main thing for me is I just didn't want any of you to be surprised if there's a noticeable financial hit.
I mean, this is very educational. I appreciate it.
Yeah, well, I think I do appreciate you telling us about the potential financial hitches, although I personally think we should stay with our current plan and not be asking for assets. But down the road, if people are going to start scamming hospitals, like you were talking about it, I could see this legislation be highly changed very quickly
But I don't want the word scam.
Yeah,
It's not a scam. They're using the laws written just like everybody does with their taxes. And there's nothing wrong with that. It just scares me because, again, our margins are thin enough that suddenly $5 million more is going to charity care per year. That's a huge risk to the stability.
Wish asked me to do an estimate of what I thought, and it was the worst case estimate that I had. It was increasing it from $2 to $2.5 million, and that's at the high end. But again, that's not accounting for behavior. Behavior changes, so it has the potential to significantly impact this and us and every other hospital in the state. It's not just us.
Right.
And,
Well, hopefully they'll react. If it's much more negative than they expect, then hopefully they will react.
and,
and make a change.
I would just say that, we're in as good a position as any hospital to absorb some additional negative ramifications. You know what I mean? We don't want to do it, but what else? We have to comply.
So, go ahead.
How difficult would it be? And you don't need to pick through the pepper to do this, but to get a sense of how much the new thresholds are costing.
Starting July 1st, going
Yeah.
forward, kind of tracking it.
Because people aren't gonna figure this out.
Right.
They didn't read this legislation. They're gonna figure it out.
It'll
once-
take a benefit review too, probably.
Yeah, so, but
No, we'll be, we watch, charities a number that we report every month.
Uh-huh.
We will be,
and it's not a huge volume. They're packets of information that we gather. So I think upfront we should start looking.
Yeah.
Tracking that so we're
I
not
think
scrambling.
we'll know a lot during the next open enrollment period if people completely switch what they've been doing in the past.
I wonder if we're the only hospital that asks for assets and other ones don't, how that would impact the people coming to KVH as opposed to asking to go to another hospital.
Well, I
like
think
that.
the leadership has already made it clear that assets are just not reasonable. You can get sued. It's
Whatever benefit we would gain, we would lose by not being able to recruit providers.
Yeah, so I think that right now, knowing what you were talking about, John, is very important because it's something for us to look forward in the future and seeing if we are having some financial impact. Knowing the other options that we could possibly lose by getting more providers and things like that, we could potentially impact us even more financially because we would not have the providers here. And so consequently, we wouldn't be able to get as many patients and take care of it. And as I always joke, what happens in Kittitas County should stay in Kittitas County. And that's what we do by getting more providers.
So, I don't want you to hear me making this recommendation. This is not a recommendation. The one place that we do have some wiggle room is we are applying this across all services. So the new law applies to hospital services. We do not have to make the change to clinic services. That being said, there's no money in the money's in the hospital. It becomes a nightmare and you don't want your patients qualifying for charity care over here and then not qualifying for charity care in another place. But that is a place that I think the laws are asynchronous.
But like you said, it's usually for catastrophic care, and that would be at the hospital.
Yeah, it is.
Well,
Is the appropriate response then to grumble about it and then watch and wait? And
yeah,
collect
I think
data?
it's just tracking. Again, I had a chance now to ask my questions, say my piece, so I have no problem moving forward so Scott can get this paperwork in a timely fashion.
It sounds like you've been doing a lot of research on this, which I appreciate.
Well, I got very curious when Scott had overtly said this change is coming, and then you start to look for those unintended consequences. And so I kept looking at summaries of the law, and at some point I said, I just got to read the law.
You've got a devious mind thinking about how people. It's good to have someone like that on the board.
We want them on our team.
Use your powers for good, not evil.
Okay, so do
You
we
suddenly
need,
get a high deductible plan.
do we need to
I've
vote on
always
this
had a high
and pass it?
deductible
Oh, all right.
plan, because that's how I get the HSA.
We need to vote on this policy. Pass it.
Yes, can I get a motion, please?
I'll move to approve it.
Moved by Matt, seconded by
I'll second it.
Terry. All in favor, please say aye. Aye. Opposed, please say nay. All right, that passes.
All right.
Thank you for taking the time to
Yeah. that would be great.
explain and
Thanks so much.
discuss.
And the people on the west side are gonna figure out the way to scam it.
They go up to 400%. So family and four, they almost have 120,000
But we're not
a year.
the 400% cover.
Yeah, but how much does it cost to live on the west side?
All right. Do you have anything else for us, Scott, or is that?
Was that enough?
You spent $1 million that we know about.
I'm financed out.
You're satisfied over there? Okay, all right, thank you so much. Michelle Worrell, Chief of Public Relations Officer.
Hey, guys. I pretty much the only thing I wanted to add is we have just signed up. The Daily Record is running a new program in coordination with a company called Hometown Welcome. And starting July, we're going to be the only medical facility that will be part of a publication that goes out to all new and relocating homeowners and renters in the county. So it covers all of Kittitas County. The estimated volume is just under 300 a month. So we'll have a direct link into new mailboxes so people know about us and our services. And we will also be receiving a database with names and addresses, so that can help us in other areas as well. So I'm excited that we'll have that opportunity. We've always been looking for an opportunity to try and capture some of that market and let people know that we're here and what we offer. And so that will start, the first mailing will be going out July 7th. Other than that, I'll be happy to take any questions. You will start seeing reports on the recruitment campaign starting in next month's board report.
I'm worried that Tricia does not have enough projects.
Yeah, she's always looking for more, and I'm sure it has been updated since I submitted this. All right, thanks, everybody.
Thank you.
Thank you. Education and board reports. Matt, do you want to talk about the retreat?
No, I'll leave that to the president.
All right. No, I thought the retreat was fantastic. I thought it was a great balance between just casual team building and also very strategic focus. A couple of sessions that we've had. I loved what do we name that session where we were use the sticky boards when we talked about for workforce development.
Yeah.
Employer of choice.
Employer of choice. Thank you. I thought that was particularly gratifying to participate in and to play with the big boys and brainstorming, and that was really great. Anybody else want to speak about any particular item that we participated in?
You covered it.
Yeah.
That was good.
Yeah, I'll second what you said. It's really helpful to kind of get away from this facility, spend some time with individuals, not just in their role, but as people, and develop a little bit of that rapport. And, just it's great. You feel more comfortable sometimes being able to approach them the rest of the year because you built up the relationship.
Yeah, I agree with that.
So that being said, now would be the time for us to start looking for next year's retreat. If that's
Can we order better weather for next year? It was so windy that there was one of the Campbell's employees was pushing one of those resin carts with dishes and things on it, and the wind picked up the entire cart and tossed it down the parking lot. And it was just, so it was windier there than here.
We thought we would look at both Chelan and Marcus Whitman in Walla Walla.
Does media hold any potential purpose?
We thought people would be, not that we
Too
don't,
close to home.
yeah, we thought people would be too easily distracted. if they were- And Skamania was another option. So we thought we'd look outside if it's the will of the board to do plan a retreat for 2023.
Cover space in the prison at Walla.
And I would like to again thank Mandy for organizing and pulling that off. you for that.
Is that a yes?
But yeah, I am definitely interested in a retreat for 2023.
Yeah.
Can we please include human not on the list of activities? We'll get there eventually, right? We did not get to do the human not, it's too close. Not far enough removed from COVID.
The only aspect I miss, which isn't very relevant, is we put it at a time of year where the family couldn't come and enjoy the off hours.
Because of school and
School and
obligations.
stuff. So I don't know how relevant that is, but it was a different feel for me during off hours, because I was there by myself this year.
Sure.
So, but that's obviously not a primary.
Yeah, I'm open to other.
All right,
calendar.
we'll bring some stuff forward.
Perfect, thank you. Any old business? I don't see anything. Or new business? No businesses, okay. At this point, we will recess to executive session to discuss
Real estate and personnel.
real estate and personnel per RCW 42.30.110. Open, speak and speak. And we need
40 minutes.
40 minutes.
8:05.
8:05, 5 minutes enough?
Yeah.
We can do here at enter executive at 8:10,
Sure.
and then
Will there be any?
reconvene to
No
open
action.
session
No
at
action.
8:50. Okay, perfect.
Yeah.
Thank you, everybody.
Thank you.
Thanks all.
Thank you very much. How are you doing?
Good, I'm done.